Day. So what is the importance of these days? Why we celebrate these days? Like why we celebrate our birthday? So that we realize that how much improvement has happened in us, how much deterioration has taken place in our behavior. So that is basically the meaning of celebrating the birthday. Same way, I believe that these kidney days, we have got, every year we have got a theme. And because we have a theme, we work on that particular theme the whole year and try to improve the health of our society. We try to improve and give benefits, health benefits to these people, and try to see a healthy society. International Women's Day is celebrated on 8th of March. Then World Kidney Day is celebrated on 10th of March, and World TB Day is celebrated on 24th of March. Now, what is the significance of International Women's Day? This year, what is the motto of that? Mission is that no bias. So there should be no bias as far as gender is concerned. Now, Women's Day, what does it Women's Day tell us? In Sanskrit, there is a proverb saying that Yatra Naryastu Pujjante Ramante Tatra Devata. It means that wherever a woman is worshipped, all the deities install themselves there. That is the importance of a lady. That is the importance of a woman. Remember one thing that you see, we all know that this world started from Onkar, but as far as material world is concerned, it has started from a woman. We are born out of a woman. Woman feeds us. Woman grooms us all, whether it is a male child or a female child. She looks after the husband. She looks after the old people, in-laws and everything. So therefore, I think the role of woman in every house is immense, and therefore we must always respect woman in true sense. International Women's Day is not only giving her a basic respect as far as moral, social, everything is concerned, but more important than is looking after her health, because as you have seen many times on the TV also, you see an advertisement कि मम्मी खाना पकाने को किचन में रहती है, परोसने को टेबल पे आती है, लेकिन खुद तो अंत में खाती है. That kind of advertisements are seen on TV. What is the significance of that? That she is more happy, satisfied in feeding others and not feeding herself. But we as doctors, we as responsible citizens of India, we are not supposed to just accept it lying down. We are supposed to look after her health. We are supposed to look after her nutrition. We are supposed to look after her physical, mental, and social health. So that is the intention of celebrating the International Women's Day. The other day is like the World Kidney Day. It has been found that 10% of adult generation is ultimately suffers with CKD, chronic kidney disease. Now, chronic kidney disease is to some extent preventable, because usually it is a sequelae of infection, it is a sequelae of diabetes mellitus, and many other diseases which can ultimately culminate into CKD. As a doctor, it is our duty, because always it is said that preventive is better than cure. So there is no cure as such to a true sense for CKD. But if you can prevent CKD, can at least postpone CKD in a patient of diabetes, then there will be definitely a better quality life for the family, better quality life for that particular patient, and better quality for the society. So in a nutshell, I would like to say that as a responsible citizen, as a responsible medical practitioner, it is our prime duty to look after patients' health in such a way that they do not ultimately land up in CKD and become the prey for dialysis, because it's very cumbersome, very it costs the patient in all the sense dialysis, the physically, mentally, financially. So it is our prime duty to prevent this. And what about tuberculosis? See, as far as tuberculosis is concerned, tuberculosis is a preventable disease. And tuberculosis had been so rampant that the usual tuberculosis, what we used to read in our time when we were a medical student. After that, it became MDR-TB, medical drug resistance TB, then it became XDR-TB, and MDR-TB and XDR-TB. XDR-TB is absolutely lethal. So therefore, one has to be very careful. I remember one of my son's classmate, she died of MDR-TB, one of the toppers in the school. I felt very bad on that occasion, and I took an oath in heart of heart that every patient who comes with tuberculosis, I will see to it that we will treat them tooth and nail and see to it that they are completely cured. And we'll try to prevent tuberculosis spread or tuberculosis affection in the society to all our patients or all our individuals who come across us over a period of time. Now, therefore, these days are celebrated. We are here to, spread this particular medical word to all the doctors around. We are very happy that so far so many delegates have joined. We are extremely happy. We are grateful to our delegates that they have been joining in large numbers. We are also giving them knowledge in a large chunk, and they are imbibing that knowledge. I wish with all this knowledge they should be able to ultimately help the society in completing our mission of India or mission of world. Now I request our treasurer, the president, Dr. Jitesh Mehta, to say a few words.
Am I seen?
Hello?
Is my camera on?
Yeah, Jitesh, we can see you.
Dr.
No, we can see you.
My voice also audible.
Yeah, your voice,
Okay.
you have muted yourself. Jitesh, you have muted yourself.
Jitesh, you can start.
Jitesh, you have muted yourself.
Am I audible?
Yes. I think
you're audible, but on the screen it seems that you are.
you must be talking from mobile.
Okay. No problem.
Jitesh, go on.
Yeah, Jitesh, you can go on.
So you're not able to see me, right?
Yeah, we can see. We are seeing you also.
Okay, I can't see my camera seems to be off somehow.
No
and
problem.
I'm audible, right?
Yeah, you are audible. You are seen also. People have been seeing you the whole year and appreciating you. Now you continue.
Thank you very much. Good morning and a warm welcome to all of you online. There is some technical glitch over here in IMA, but nevertheless we are there. We are overcoming it. And it's a nice Sunday morning, and I'm welcoming all of you. There's a huge delegate who have joined us, big crowd, and I'm very happy to see that. And I welcome all of you personally. Thank you very much for joining online. We have got an array of speakers. Wonderful talks are there because we are celebrating 3 days today. All are in March. So one is the World TB Day, the other is the World Kidney Day, and the third is the International Women's Day. Now all these 3 days have their own significance. They are all different dates, but we are having it on this one day as a program. And so that is why we will be having talks on tuberculosis, kidney, as well as wonderful talks on problems dealing with women. So friends, I just want to remind that we just had a wonderful conference last Sunday, 6th of March. All those who attended in person, I'm sure they must have really enjoyed. It was a fantastic program. After 2 years, we all met in person, and we had a wonderful time. We had a wonderful increase of knowledge and interaction with the speakers also personally. And it was a very good experience that whole. Now, as the president Mumbai branch. And the next president is we shall be having our installation program on 10th of April on Sunday. And on that installation program day, I would welcome all those delegates who have come to the conference and even those who wish to attend installation program. To come on Sunday, 10th of April in the evening. So, as Dr. Girish Lal was saying, that
I think there is some internet issue in IMA Mumbai branch. They are trying to solve that. But meanwhile, I'll just update those people who have attended that beautiful conference last Sunday. For those attendees, we have a banquet coming up on 10th of April. And those who wish to attend the banquet, they can attend with their spouse. They can register with the IMA's mobile number. Registration is free, complimentary, since they have attended the conference, but they have to register compulsorily. And then only they'll be allowed to attend the banquet, which is at IMA HAD on 10th of April in the evening. There'll be installation of the new team of IMA Mumbai branch. So do register as early as possible, because we take only few numbers, because then there will be, otherwise there will be a large crowd. So try to register as early as possible with the IMA's office. Dr. Lad, shall we start with the program, because Jitesh is...
Yeah, I think.
Yeah.
I think we can start the program. Already 20 minutes, more than 20 minutes have passed.
Okay. So friends, we begin with today's...
Dr. Shubhani Madam has also joined.
Yeah. We begin with today's CME, and as Dr. Lad and Dr. Jitesh has said, we have got 3 programs coming up together. So we'll begin with the World Kidney Day program, and the first speaker is Dr. Ravindra Nikhalji. I request Dr. Dakshini Kashyap, who is a member of IMA CGP Mumbai sub-faculty, to introduce Dr. Ravindra Nikhalji. Kashyap, you are there? Okay, I'll just start. I'll just introduce. Dr. Ravindra Nikhalji is a consultant nephrologist and transplant specialist at Apollo Hospital, Navi Mumbai. After passing MBBS and MD at St. GS Medical College and KM Hospital, Mumbai, Dr. Nikhalji completed his DM nephrology from Bombay Hospital Institute of Medical Science. Dr. Nikhalji has done fellowship in the clinical nephrology, dialysis and kidney transplantation at the University of Toronto, Ontario, Canada for 2 years and was specialist in clinical hypertension. Dr. Nikhalji has had wide exposure in transplant immunology, deceased donor kidney transplantation, and after cardiac death donor kidney transplantation, and has gained expertise in the management of highly sensitized, ABO incompatible, and immunologically high-risk kidney transplants. Dr. Nikhalji has presented multiple papers at national and international conferences and has several publications in peer-reviewed journals to his credit. Today, Dr. Nikhalji will update us on when to refer a patient to nephrologist. Over to Dr. Ravindra Nikhalji.
Thank you so much, Dr. Anil Awad, sir. Thank you, Dr. Girish Lad, sir, and thank you, Dr. Jitesh Mehta, sir, for this kind introduction. It's an honor to be speaking to all of you on the occasion of World Kidney Day. And I'm going to quickly take you through the my topic today. So this is my title of my topic, when to refer a patient to a nephrologist. So my distinct slides are seen, right? Hello.
No,
Sir,
no.
you have to share your screen, sir.
Yeah, I did it, sir.
I don't think so. No, sir, you are not shared.
Just a minute.
Click that green button, na, sir. Yeah, yeah. Now, yes, right. Yes, now we can see.
So this is the title of my talk, sir, today. When to refer patients to a nephrologist. This is by no means, an attempt to increase the referral services to nephrology, but just to make you, all of you aware, like when we actually need to see patients, where we can make a difference in the clinical outcomes and prevent, as Dr. Girish Lad said, we can prevent chronic kidney disease, which is such a great burden on our society at large. And to a large extent, after a certain stage, chronic kidney disease becomes an intensely progressive disease where we can do offer very little if the patients are referred late. So there are certain things that all of us should know as a primary care physicians in a day-to-day practice. Some myths, some common misunderstandings that we have to understand and start referring and following these guidelines. So first and foremost, the best known marker for a kidney function, creatinine. So we all know that normal serum creatinine level within the normal range may not always be normal. It varies from age to age. There are a lot of factors which determine the level of serum creatinine in the blood. Of course, the most important factor being your kidney function, but there are many other factors which can determine the level. And you have to interpret the serum creatinine level in the light of the patient's age, sex, and patient's comorbidities. So a creatinine level of 1.2 or 1.4 at at different ages and at different clinical scenario may not mean that patient have same glomerular filtration rate. Okay, so what is so I think all of us are aware that now as a nephrologist, we are more and more keen and more interested in knowing what is the GFR or the glomerular filtration rate. So GFR basically means it's equal to the sum of the filtration rates of all the functioning nephrons in the kidney, and it gives you a best overall index of kidney function. So more than creatinine, GFR tells you a lot about the your kidney function. So glomerular filter approximately 180 liters of plasma every day, and normal value of GFR depends on age, sex, body size, and there is a considerable variation from person to person. So all of us are endowed with a good GFR at birth. Okay, so in the when we are born, when we are young, the GFR is extreme. GFR is in the higher in the like more than around 100 to 120, and as we age, as the number of functioning nephrons decline, the GFR starts declining, and by age of 70, most of us will have some form of a CKD, and that on the top of other comorbidities like blood pressure, diabetes, ischemic heart disease add further to the burden. So why measure GFR and why not only creatinine? Now creatinine is very easily available. Like it's a very simple blood test. Every lab does it, but still it is better to do GFR, or I mean, of course it depends on your creatinine level, but it's better because it tells you a lot more about your kidney function. So it helps you to detect kidney disease. It helps you to categorize the kidney disease. It helps you to tell you what is the severity of the acute or chronic kidney disease, and it also helps you like in prognostication, making decisions about diagnosis, treatment plan, and so on and so forth. We should also know that decrease in GFR actually precedes the onset of kidney failure. So if you are monitoring somebody GFR trajectory over a period of time, you will know that if the falling GFR, even the patient's creatinine level is within the normal range, it will tell you that patient is approaching or patient is developing chronic kidney disease. And this is so common on a patient with a diabetic, patient with underlying type 2 diabetes, patients with hypertension, or patients with ischemic heart disease. You follow their trajectory of creatinine, Initially, creatine level remains normal for a long period of time. There's this honeymoon period, and then the creatine starts sliding down, and its progress is very fast. So we can do something, if you detect it earlier. Now, all of us know that persistent reduction in the GFR of less than 60 ml per minute, which is nothing but stage 3 chronic kidney disease, portends very bad or adverse outcomes of chronic kidney disease, including progression of not only progression of renal failure, but it is a very, very important and potent risk factors for chronic vascular disease. All of us, our patients, have underlying either known or unknown manifest or unmanifest chronic ischemic disease, and most of them will ultimately fall victim to the underlying cardiovascular disease. So not only the GFR of less than 60 ml per minute, but any other markers of kidney damage like proteinuria, hematuria, any radiological abnormality will help you to indicate that patient is probably having a chronic kidney disease. So creatinine is a flawed filtration marker. So we do measure creatinine from time to time, and even as a nephrologist, that's our like a common tool. But we have to understand that it is not one of the most ideal filtration marker. So creatinine is excreted by the kidneys by glomerular filtration, and it's a readily available marker to measure GFR. However, it is also secreted to certain extent by the proximal tubules. So it's not only the filtration, also some amount of excretion by the proximal tubules. So actual creatinine clearance may exceed the GFR. And the generation of creatinine is primarily determined by your muscle mass. So as of so people at extremes of age, people who are malnourished, people who are amputated, people who are very sick, people in the ICUs, cirrhotic patients, patients with heart failure, for that matter, anybody who has lost muscle mass, creatinine does not give you a very accurate picture of your chronic kidney disease or a GFR. And to a certain extent, as the kidney function starts declining, there is some extrarenal elimination of creatinine in the gut. So that helps to compensate a bit, but all in all, creatinine is not a very perfect ideal marker. This is just a perfect example. What does creatinine at different ages mean? So somebody who has as 22-year-old man, creatinine of 1.2 means a good GFR 98 ml per minute. Same at age of 58-year-old male, 1.2 creatinine means your GFR has fallen by almost 33 ml per minute. So you are already in stage 4 CKD. And 80-year-old female, 1.2 creatinine gives you a GFR 46 ml per minute. So stage 3 CKD. So never depend on serum creatinine alone. Follow the creatinine trajectory. It gives you, and please measure GFR whenever possible. It gives you a lot of information. Another marker called cystatin C, it is again freely filtered by the glomerulus and then reabsorbed. It is not secreted by the proximal tubules. So only a small amount comes in the urine, so we cannot measure urinary clearance. And generation of cystatin C in the body is less variable than the serum creatinine. It is not so much affected by the age, sex, or your muscle mass. So it may be a little better marker than cystatin C. So if you are in doubt about the value of creatinine, if you get an incidentally high creatinine value, you may cross-check with cystatin C levels. Again, this is a widely available. And we find this is at extremes of age or at higher levels of GFR, this may be a better marker. And somehow it correlates well with adverse outcomes in the CKD. So the GFR estimation is important to your current level of GFR is important to estimate your CKD detection. So if you have a low GFR less than 60 ml per minute persistently over more than 3 months, probably there is some underlying chronic kidney disease. It also helps you to evaluate a kidney donor. Now, when we do kidney transplants and we start evaluating a potential donors, it is very important to know what is the GFR total as well as the individual GFR. That helps us in making a proper decisions whether a particular individual is suitable as a kidney donor or not. Any change in level of GFR, either rapid decline, that means patient is developing acute kidney injury, and a slow decline helps you to detect that the CKD is progressing. Now, high creatinine, incidentally high creatinine, what we should do, what is next? So essentially, any level of high creatinine will fall in these 4 categories. Whether the patient is suffering from acute kidney injury, which is by and large reversible if you detect early and treat early. If the patient is suffering from chronic kidney disease, better to go in the history, better to go in the previous lab reports and find out if the patient had high creatinine in the past. And unfortunately, no matter what, most of these chronic kidney diseases beyond a certain stage are relentlessly progressive and become largely irreversible. Whether it's an acute or chronic kidney disease, somebody who is having a stable kidney function over a period of time and they suddenly start GFR declining. And then you need to understand what is the reason, if there are any acute factors like dehydration, drugs, infections, or it is just the CKD progression. And always try and measure GFR when the creatinine is in steady state. So this was the most important kind of aspect of my talk today. So don't depend on the creatinine alone. Please measure the GFR and follow the trajectory. Okay. So now second important CKD parameter is proteinuria. Okay. So whenever you have like a lot of time, you see the diabetic patients, they get urine reports and they only have the urine sugar testing. We never get a proper urine test. So please look at their on the initial routine urine analysis. Please see if the patient has trace 1+, 2+ proteinuria, and please try and quantify it whenever possible. It gives you a lot of information and it precedes the onset of chronic kidney disease in most of the chronic kidney disease patients. So when you then the fourth important fact about any chronic kidney disease is, please be aware of the medications that you are prescribing or the patients are inadvertently taking. Like most of these over-the-counter prescriptions, NSAIDs are the famous culprits, aminoglycoside antibiotics given casually for UTIs, and obviously with a high amount of radio contrast agent either done for the CT scans or the coronary angiographies. So it should be used with a lot of appropriate precautions, and patients should be warned that these drugs can uh, reversibly or irreversibly increase the creatinine, and you should take appropriate precautions. ACE inhibitors and ARBs, famously the most important drugs for the prevent CKD progression to protect proteinuria. These drugs also should be used quite judiciously, and try and withhold these drugs if patient develops any of the insults like diarrhea or patient is undergoing radio contrast exposure. So we can hold these drugs temporarily because they may add to the renal insult. And most of these patients should be protected with some form of a cardiovascular, some form of a secondary prevention for cardiovascular disease like aspirin and statins. Okay. Then uh, whenever you are faced with rising creatinine on somebody who is taking ACE inhibitors or ARB, please do not just automatically discontinue ACE inhibitors or ARBs just because the creatinine has increased by few points. So all of these drugs will have initially caused 25% increase in the creatinine, which settles over a period of time. This is the hemodynamic effect of any ACE inhibitors, ARBs, or now the SGLT2 inhibitors. Most of us and a lot of us are using SGLT2 inhibitors now, left, right, center for various indications. So it is not only a glucose lowering agent, but it's also become a protective drug for your CKD. It is become a protective drug for your congestive heart failure patients with reduced ejection fraction. So all of these drugs, when used together or when used in isolation, may cause reversible decline in the GFR. But it is prudent to continue to use these drugs and withdraw only if there is much more, I mean, more than 30 or 35% decline in the GFR. Okay. So anybody, again, the low hemoglobin in patients with chronic kidney disease, please investigate appropriately with serum iron studies, serum ferritins, and serum vitamin B12, folic acid. And most of these patients will need erythrocyte stimulating agent, ESA, like something like erythropoietin, to boost the hemoglobin. And we need to maintain the hemoglobin between the range of 10 to 11. Do not try to overcorrect the hemoglobin because it has its own side effects. It can cause strokes, it can cause AV fistula clottings. So anemia should be handled judiciously with the use of iron and iron erythrocyte stimulating agents. Please avoid phosphate containing enemas in bowel preparations for any patient with CKD. It can dangerously elevate the phosphorus levels. Again, routinely used antacids which contain plenty of magnesium or aluminum should be avoided in patients on long-term basis. Same applies to proton pump inhibitors. A lot of these drugs are known to cause interstitial damage, and patients keep on taking these drugs without be even knowing that patients are on these drugs for a long time, and they do cause irreversible decline in the kidney function. Many of our patients with hypertension, I mean, not everybody, but some of them should be screened for secondary hypertension. Okay. There are a lot of clinical clues that you get, like essentially resistant hypertension, patients who drop their GFR on putting them on ACE inhibitors or ARB, patients who have hematuria or proteinuria in association with hypertension. It may tell you that patient may be suffering from underlying kidney disease, or kidney disease may be the reason for his high blood pressure. So though not secondary hypertension is not very common among the patients with systemic hypertension, but please be careful and try to find clues if, because these form of hypertension can largely be controlled and cured well. Patients who are coming to you with recurrent stone disease, I mean, we see patients like who come back with multiple procedures done, laser lithotripsies, interventions, DJ stenting, and nobody has ever tried to look at why these people are developing recurrent stones. They may be suffering from primary hyperoxaluria. Stone disease is number 3 or number 4th cause for chronic kidney disease in our country, and it is really preventable if you start treating them early. If you try and find the cause or metabolic cause for their kidney stones, these diseases are manageable well. So somebody who is coming with recurrent stones, recurrent infections, urinary tract infections, please try and find out if there's any underlying cause for this, because you lose an opportunity to treat CKD once these patients start developing decline in the GFR, and then interventions really do not help. Now, some of the drugs which we typically use in kidney transplant patients like cyclosporin, tacrolimus, I mean, you will be seeing these patients who are on these drugs for some other reasons, and you'll be adding certain medications to treat their infections or any other symptoms. Please be aware that these drugs have wide interactions and they really interact with lots of other medications. So we need to find out if this whatever drugs you are prescribing to these patients are going to interact with cyclosporin or tacrolimus. So, I mean, this was some of the common, points that I have learned as a nephrologist practicing, and which I have found that how to practice medicine better, how to practice nephrology better, and how to make a difference in the outcome, how to make how to prevent CKD, how to diagnose CKD at an earlier stage, and give these patients really a good life. Now the second part of, or the, the title of my talk, when you start thinking of these patients should be referred to nephrology. Now you are aware that I mean uh, luckily as a city of Mumbai have enough nephrologists. I mean there's still uh, uh, not enough to take care of the CKD load, but then at certain point in your practice you should start thinking of nephrology referrals. So I mean, I would put it simply like whenever you are in doubt, simple dictum is, as my boss, Dr. Ashok Ruplani, taught us many times, whenever in doubt, refer. I mean, this is not only for a nephrology. It's for us nephrologists too. Whenever we're in doubt about anything, please, we were taught to refer to an appropriate specialty immediately. Don't, we are told, please don't keep playing with the patients. If you don't understand what the patient is having chronic cough, please refer to pulmonologist. Unexplained chest pain, please refer. So this was what whenever you are in doubt about kidney problems, your patient's creatinine values, your patient's urinary analysis, your patient's sonography findings, I think it's best, and it's in the common interest of patient and doctors, it's better to refer to these patients. So, I mean, I'll give you general guidelines when you start thinking about referring. So, when you are uncertain about the cause of either it's an acute kidney disease or a chronic kidney disease, as I said, acute kidney disease are largely reversible. Chronic kidney disease are unfortunately beyond a certain stage are relentlessly progressive. So, when you are faced with such situation, I think it's better to refer these patients to an appropriate specialist. Whenever you see an abnormal urine analysis, like red cell RBCs, lots of RBCs in the urine, lot of protein in the urine, when you know that patient has a family history of kidney disease, I guess these patients should be referred. Then you'll be seeing a lot of CKD patients in your practice, and these patients are stable. These patients' creatinine values are quite stable. These patients are best managed by a primary care physician. But then certain conditions, certain complications in CKD patients, like persistent anemia, when if you want to start erythropoietin stimulating agents, patients with CKD who are in fluid overload, patients with CKD who are refractory hypertensions, patients with CKD who are developing persistent hypoglycemia, severe mineral and bone disorders, backaches, fractures, okay, persistently high potassium. I mean, these are the things which need a lot of attention to their diet, a lot of attention to their diagnosing complications at the earlier stage and preventing them. So I think these patients probably can be referred. And whenever you know that patient's creatinine is rising or patient's GFR is less than 30 ml per minute, And these patients need to be prepared, counseled for future renal replacement therapy. I think this is the point. If I would say a GFR of less than 30 ml per minute, these at this stage probably you should start referring. So I think I already said about these certain indications. Another thing is the systemic illness. Any systemic illness with a renal involvement. For example, young girl with joint pains and proteinuria. Uh, you know, clearly, like probably lupus should be ruled out. Elderly patients with unexplained kidney problem, anemia, multiple myeloma should be ruled out. Elderly patients with chest shadows, breathing difficulty, and high creatinine, vasculitis should be ruled out. So any systemic illness where you think that kidney, where we can make a difference, and where kidney biopsy may help, or the additional immunological testing may help, I think these patients should be definitely referred. So, I mean, there are various forms of referral. I mean, we are always available as a nephrology community. I mean, we are always available. So, I mean, immediate referrals, direct phone calls, urgent outpatient referrals, routine OPD referrals. I mean, there are types of referrals. So, immediate referral when you know that patient is suspected acute kidney injury and patient is kidney function is declining rapidly, and patients having a dangerous complications like hyperkalemia, fluid overload. Obviously, I think it's better that these patients are immediately referred because we can treat acute kidney injury, and acute kidney injury is a forerunner of chronic kidney disease. A lot of time, acute kidney injury does not recover, and these patients are left with underlying chronic kidney disease. Many times you will see that patients' creatinine does not reverse completely, and they're left with stage 3 CKD, and the preceding event is acute kidney injury. So if we can pick up acute kidney injury in the earlier stage, treat them, I think we can prevent CKD. Okay. So, I mean, obviously the bladder outlet obstruction needs to be treated immediately by either putting a Foley's catheter or intervention like either cystoscopy and or prostate surgery. Malignant hypertension, and anybody with hypertension with an secondary target organ damage, left ventricular failure, acute kidney injury, Press syndrome. Yeah, I mean, these patients should be immediately referred. And then patients to be referred as an outpatient. I mean, so I mean, unique to the nephrology and nephrotic syndrome. I mean, somebody who has a 3+, 4+ proteinuria in the urine analysis, or a proteinuria of more than 3.5 grams on a 24-hour urinary protein excretion. I mean, this is definitely I mean, these patients, most of these patients will need a biopsy and some form of a immunosuppressive treatment. So I think these patients should be definitely referred. Anybody with rapidly progressive renal failure, creatinine rapidly increasing, yeah, I mean, there we need to find out with the vasculitis whether they have any glomerulonephritis. I think these patients should be referred because these patients, most of these patients will need a biopsy, and these patients will need some form of a immunosuppressive treatment in the long run to protect their kidneys. So these patients can be referred. Okay. Systemic illnesses with renal dysfunction or a proteinuria or a hematuria, it is important to diagnose these patients earlier because they can be treated systemically as well as renally. So again, it becomes important. And whenever you suspect, as I said, vasculitis, lupus, multiple myeloma, it's important. So any of these urinary abnormalities with worsening renal function, where we need to find out the cause and reverse, yes, I mean, they become an indication for referral. Persistent hyperkalemia with either normal or abnormal kidney function. I think, because at certain point it becomes life-threatening and patients do land up in the emergency with abnormal ECGs or complete heart block, and it can be a life-threatening situation. So whether a patient has chronic kidney disease or no chronic kidney disease, I think these patients should be evaluated appropriately if they have any renal cause for hyperkalemia, if there are any drugs which can cause hyperkalemia. So again, most of these indications, as I talked earlier, also become indication for the routine referral. I mean, not urgent referral, but at some point, they should be seen by a nephrologist in their journey of chronic kidney disease. So all the patients with stable chronic kidney disease, stable GFRs can be seen, at certain stage, and anybody who is stage 3. So GFR of less than 30 ml per minute should be with under a regular follow-up with a kidney specialist because it really makes a difference. We can still do better. We can still prevent the onset of stage 5 or end stage kidney disease by appropriate dietary interventions, by appropriate medicines. Okay. Again, as I said, proteinuria, hematuria, they do indicate the underlying renal cause, and most of these patients end up with biopsy. So please refer. This is a rough guide as the level of GFR when the reference should be made to a nephrologist. And I said previous, anybody less than 30 ml per minute probably should be referred at earliest. Somebody with a GFR of less than 15 ml per minute who is nothing but a dialysis candidate or a renal transplant candidate should be referred immediately. Now, in the diabetes needs a special mention because that is number one cause for chronic kidney disease. Most of our patients, almost 70% patients requiring dialysis or kidney transplant are diabetes. And if not diabetes earlier, they develop diabetes later on. So I think diabetes is a very, very challenging problem in our patients. So in a diabetic kidney disease, whenever you suspect that they have developed non-diabetic kidney disease, like if their kidney function is deteriorating rapidly, they have too much of a hematuria, or they have other systemic illness, I think this becomes a point to diagnose this patient, because many times we assume that diabetic patient will have a diabetic kidney disease, and we lose the window of opportunity to treat non-diabetic kidney disease. So, I mean, there are ways to diagnose these. I mean, most of them may need a biopsy, but then whenever you suspect that diabetes kidney disease is progressing unexpectedly faster or having a lot of hematuria, absence of your retinopathy, I think this becomes an indication to refer to diagnose non-diabetic kidney disease. Anybody who's suspected having possible familial renal disease. I mean, commonest example being autosomal dominant polycystic kidney disease, where generations of people have this polycystic kidneys, and if not treated appropriately, they develop chronic kidney disease in the end. And we all know that now chronic this all polycystic kidney disease is largely treatable with tolvaptan. So these patients should be referred earlier when their GFR is in the normal range, because you can start them on these drugs and we can stabilize their GFR. Recurrent kidney stones, we need to rule out if they have primary hyperparathyroidism, whether they have primary hyperoxaluria. So I think it is important to have a metabolic evaluation for these patients with recurrent renal stones. So I think at some point we should see them. Refractory hypertension, whether it's a renovascular disease or renal parenchymal disease, or it's an endocrine hypertension, you will have some clues. And if you think that it is not a primary hypertension, I think it becomes an indication. So I guess I have given you a rough overview of how, what are the common things in nephrology where you should start thinking if you need to refer. And yeah, we, by referring earlier, we do make, we can make a difference. That's the point. And whenever you refer, I think we need to have a complete database. So we need to know the general medical history, all the medications that patients have been taking throughout. The family history is very, very appropriate. Then all their relevant investigations. I mean, most of the time we miss the urine analysis reports. I mean, it's so important to have urine analysis in all these patients. Whatever the blood tests that are available, please look at the serology. Please look at the hepatitis B, hepatitis C, and HIV also, because I mean, these patients need to be vaccinated. Appropriate imaging, basic sonographies. Now, lead referral is not a Indian problem; it's a worldwide problem. And it's not like it's not the kind of trying to shift the blame games. But then, yes, I mean, it's patients do come late. I mean, patients present late. I mean, it's nobody's fault. And a lot of times we see patients who are already in advanced chronic kidney disease, and then we don't have really much to offer except counseling them for renal replacement therapy, which still in India is not widely accessible. Transplants are, I mean, yes, we do a lot of transplant, but then not everybody is eligible for transplant, and it becomes a costly affair in the long run. I think some of my esteemed colleagues are going to talk to you about various ways to transplant, but I mean, it's as Dr. Girish Lad sir said it. I mean, prevention is better than cure, and this applies very, very aptly to this part of this disease, chronic kidney disease. So, I mean, when we see the patients late, I mean, of course, there are consequences, and consequence being increased mortality and morbidity. I mean, patients don't have AV fistula in place. We have to put a catheter and we start dialysis. So it leads to a lot of complications. Of course, patients have to get hospitalized in the emergency. So increasing cost and duration of hospitalizations. We have to depend on the temporary catheters, which are really a nightmare. Most of them get infected immediately. When you start dialysis on an urgent basis, or when you crash start dialysis, outcomes are not same as when you start dialysis in a timely fashion. When you start dialysis as a crash, we have lost a lot of opportunity to treat their metabolic bone disease. We have lost a lot of opportunity to treat their anemias. We have lost a lot of opportunity to treat their cardiovascular disease. And these patients sadly do not live longer, and that is one of the main reason is being we really see them quite late. And uh, access to renal transplantation is not universal. There are a lot of problems there. So, I mean, if we see these patients early, and I mean, of course, we have our own patients and we keep seeing them. So, I mean, these patients can be taught well. I mean, they can be counseled well. They can be prepared for dialysis. We can have AV fistulas in place. We take care of their calcium, phosphorus, parathyroid metabolism. We can reduce and prevent chronic cardiovascular disease so that these patients do not die suddenly. So, yes, we can change the outcome. I mean, it is not really so pessimistic there. So, I mean, I think I have said what I need to say, and I will stop here. Thanks for listening to me on a Sunday morning, and I will end my slide with this. This was what famously taught to us by my boss, Dr. Ashok Kriplani. Whenever in doubt, please refer. Thank you. Thank you, everybody.
Thank you, Dr. Nikhalji, for an excellent presentation. A very simplified way of presenting your topic. There are a few questions, sir. What
Yes.
are the investigations for immunological renal disease?
So the immunological renal disease, basically, we should categorize as per the age. So anybody who is young at extremes of age, basically. So anybody who is young and presents with either hematuria, proteinuria, or a rising creatinine, we should look at lupus markers. So ANA, double stranded DNA, complement levels. Vasculitis is always kind of a hidden thing. So serum ANCA levels and anti-GBM levels, especially at extremes of age. And in elderly patients with anemia and unexplained renal failure, serum protein electrophoresis, light chain analysis, free light chain analysis. These are the basic immunological markers that we look at all patients.
Okay. Sir, how to manage long-standing cases of hypertension with left atrial enlargement? Which test should they be undergoing for kidney functions?
Sorry, sir, please repeat it. I missed it.
How to manage a long-standing case of hypertension with left atrial enlargement?
Left?
Atrial enlargement. I really don't.
Okay, sir. I mean, left atrial. Is this left
But
ventricle?
ideally, hypertension should cause left ventricular hypertrophy. I don't know. Okay.
I
There's
mean,
one more
sir, I mean,
question.
probably,
How?
I'm not sure if there's any specific drug in this situation. I mean, probably getting the blood pressure down to 140/90 with ACE inhibitors, ARBs, or a beta blockers. Probably, I think in these situations, maybe beta blockers would be a better drug, or for that matter, even ACE inhibitors or ARBs. But I'm not sure, sir, like hypertrophy, I mean, systemic hypertension with left atrial enlargement specifically, maybe a cardiologist would be better in that situation.
So this serum cystatin C level test, is it available? I mean,
Yeah. So many labs do it. So you have to just tell them. I mean,
okay.
and
What is
you
the
can even
cost of it?
correlate your serum creatinines with serum cystatin, sir. It's a really good marker. If in doubt, we can do that, especially at extremes of age, like pediatric population or an elderly population where the creatines are borderline high, and you don't know that whether this is really true or this is just a like one of the abnormal tests.
what is the cost of the test?
No, it's not costly, sir. It's hardly, maybe 200, 300 rupees. Sir.
Okay. Any questions from the panelists? Jitesh?
Dr. Kashyap, I have a question. Is there a diabetic CKD?
Hello?
Hello. Yeah, Dr. Kashyap here. I have a question. Is there a role of microalbumin the diagnosis?
I'm not able to hear you, sir.
Kashyap, I think you switch off one off. You are sitting next to Jitesh, I suppose. There's an echo coming up. Now you can talk. Hello,
Yes, sir.
Kashyap, go on. So there's one more question is there. Yeah, Kashyap.
Yeah. Yeah. Am I audible?
Yes, follow.
Yeah. Sorry, I think there were two mobiles touching together. So, is there a role of microalbumins in the diagnosis of diabetic CKD?
Yeah, obviously, yeah. So that is the first first parameter which gets abnormal. So it starts as a microalbuminuria and progresses through the different stages. So I think every 6 monthly or 3 monthly, probably you should test for microalbumin in a diabetic patient.
So there's one question from Dr. Yashwant Sathe. Recently, I had a 52-year-old female patient presented with marginal renal compromise, creatinine 1.48 and 3+ proteinuria.
Yeah, I read it, sir. Yeah. So this could be elderly, sir, any elderly patients with pulmonary renal syndrome, like you have a chest symptoms and kidney symptoms.
No.
Yeah, I mean this could be very well good features. I mean, unfortunately, it's a very aggressive disease. So and antibody levels. So these anti-GBM antibody levels are very specific. So that will clinch the diagnosis, and this patient should be treated aggressively. It could be good patches. Yes, sir.
Sir, what level of serum creatinine you feel that patient should be referred to nephrologist?
So the creatinine level, I mean, as I said, I mean, this is based on the GFR now. It is, I mean, it will vary from patient to patient, but anybody who is stable at like say something like 3 or more than 3, probably we should start seeing, because usually the GFR 3 means creatinine of 3 for most of patients. GFR has fallen to less than 30 ml per minute. Okay. So at some stage these should be seen by nephrologist.
Okay.
This is GFR test again, sir. I'm just scrolling through the questions. GFR test, sir, it is basically, I mean, it's a calculation. I mean, it's not even. Most of the labs are reporting automatically, and so it's very easy to monitor. You have calculators which are online available.
Yeah, there are formulas for that.
Yeah.
Okay.
And
one more question, last question, I think so.
So recurrent renal stones is a very, I mean, it's a vast topic, sir, but we should rule out hyperparathyroidism first. And anybody who is young and developing kidney disease, you should rule out primary hyperoxaluria. Now, I mean, it will become a topic by itself, sir, to how to prevent recurrent stones. Yeah. But metabolic evaluation is important. And these patients do very well with hydrochlorothiazide diuretics, because most of them patients will have a hypercalciuria as the kind of reason for the stones.
Okay. Thanks a lot, Dr. Ravindra. It was a really wonderful lecture, and though you did not intend, but the nephrologist referral will definitely increase after your lecture.
So much, sir. That was not the intention of my talk.
I know you did not intend for that, but see, it's a very important thing, because you mentioned about the late referral problems also. So many times when the physician refer the patient late to the nephrologist, they also cannot do anything. Anyway, thanks a lot.
Thank you, sir.
And we now move on to our next speaker, and that is Dr. Shruti Tapiawala. And I request Dr. Dakshini is there?
Yeah.
Yeah, he will introduce Madam Tapiawala.
Good friends. Dr. Shruti Tapiawala is a consultant nephrologist and transplant physician at Global Hospitals and Sir H.N. Reliance Foundation Hospital and Research Center. She is the Mumbai director at Advanced Transplant Diagnostics and Immunogenetics Lab Private Limited. She completed her MD in internal medicine from Nair Hospital and TN Medical College, followed by DNB in nephrology at PD Hinduja Hospital. She then completed fellowship in nephrology from University Health Network, North America, fellowship from the American Society of Transplant, and fellowship in HLA medicine and advanced transplant diagnostics. She is trained in multi-organ transplant and HLA medicine at the Multi-Organ Transplant Unit, University Health Network, Toronto, Canada. She is the secretary of the Indian Society of Nephrology, West Zone Chapter, and joint secretary of Women in Nephrology, India. Her areas of interest are immune stratification and post-transplant immunology monitoring and care of transplant recipients, sensitized patients transplant, renal nutrition, and prevention of kidney diseases. Today, she will speak on ABO incompatible kidney transplant and kidney paired donation exchange.
Good morning, everyone. Can I share the screen?
Yes, ma'am.
Okay. Good morning, everyone. Thank you for the introduction and the kind invite. I'm happy to be on this forum. IMA is like home to us in Mumbai because it is a close-knit group of physicians who try to work hard to help patients get better. So I'm happy to be on this forum. And today's topic seems a little complicated, but I have made it extremely simple with few active case reports. So whatever cases I have managed in the last 20 years of practice in Mumbai and abroad, I have added all of them so that it gives a practical know-how. So let me just start with the basic premise of a transplantation. So what is the meaning of transplantation versus transfusion? Because we all understand transfusion means transfer of blood. When you transfuse blood, you do get reactions, and they are blood group related reactions. When you transplant, you are transplanting a tissue. So you're transferring a tissue or an organ, and you get T cell mediated reactions. So we have to understand that whenever a transplant happens, there are basic principles, and the basic premise is that a renal transplant means that someone else's tissue organ is coming into us. Foreign tissue which is transplanted is identified by the patient's body, and the mismatch leads to formation of antibodies against the tissue, which leads to attack to the allograft or the transplanted organ. And this is important because we need to protect the allograft against the attack from our own body when we are transplanting. HLA and blood group. These seem to be the important barriers which we have to respect when we are going through transplant. So blood group antigens, major histocompatibility antigens, which you know as HLA antigens, which we do for matching. Why do we do these for matching? Because we need to understand how much is matched with the recipient, how much is mismatched. The more the mismatch, the body is going to see more mismatches and have more chances of rejection. So that is why we try to see how much is matched with the body, and the body will not react to this. Let us look at the blood group first. So which is the topic today, that ABO compatibility is required. Whether we do a blood transfusion or whether we do a transplant, we need to see that the blood groups are matched. Because by chance, if a transplant happens across the blood group barriers, we can cause an hyperacute rejection, like we have a blood transfusion reaction with a wrong blood group and the patient can pass away with the reaction. Similar can happen with the kidney. In the case of a kidney, you will have to explant the kidney and throw it away to save the patient. But in blood transfusion, there is nothing you can do and sometimes you can lose the patient. If you want to think of transplanting across the barriers, then you will have to do a lot to see that the blood group mismatch does not affect the transplant, and which I will show you in the next few slides. So we all know that donor blood group O is a universal donor, can donate to O, A, B and AB. Blood group A can donate to A and AB blood group patients. Blood group B can donate to B and AB blood group patients. Blood group AB can receive only from AB, is a universal recipient, but can give only to AB because AB will have no antigens over there. There is a 35% chance that any two individuals, so whenever we see end-stage kidney disease patients and we look at whoever is available to donate a kidney, we find that 35% of the times, two individuals might be blood group incompatible. So 1/3 of the potential living donors are excluded immediately due to blood group incompatibility. And you must have heard that your patients must have come and told you that I want to go through transplant, but my donor is not matching with me on my blood group. So I'm still on dialysis. And like Dr. Ravindra just pointed out that not everyone is lucky to go through transplant. So this is one of an important barrier which keeps people on dialysis sometimes. That was related to blood group. How does a rejection happen? There are tissue antibodies, HLA antibodies in the patient's blood against the donor kidney, which are known as donor-specific antibodies. These can attack the transplanted kidney, cause severe rejection and loss of the kidney. It can decrease the life of a transplanted kidney. Blood group and HLA tissue. These are the two most important barriers which we need to understand when we are doing a transplantation. And if there is a mismatch, we need to know how to handle it. How do these HLA antibodies come? Blood group antibodies are already there. How do these HLA antibodies come? These come because people get transfusions. So the transfusions come from different individuals and the genetics or the HLA tissue of a different individual comes into our patient. And that can induce antibodies. Women who have multiple pregnancies will be exposed to multiple genetics, and that is how they will get antibodies formed in their body, most towards their husband or towards their partners. Previous transplants, because here again a foreign tissue had come into your body. Viral infections. COVID luckily has not induced a lot of antibodies, but flu, for example, influenza, spontaneously makes a lot of tissue antibodies and these patients get sensitized. Sometimes people spontaneously have a lot of antibodies. Now, why am I talking about blood group antibodies and HLA antibodies? Because these are the two premises where we need to work hard when we are doing transplantation when they are mismatched. So as I told you, these can cause rejection. These can cause a kidney to die on table and we may need to remove the kidney and the kidney turns blue. So how will we know that someone has these antibodies? Blood group we can test very easily in the blood bank and come to know if there is a mismatch. But how will you know that this XYZ patient has antibodies and it is a higher risk of rejection? The cross-match with the potential donor will come positive, which is a tissue cross-match. And there are now sensitive technologies available to identify HLA antibodies and to assess if these are specific towards the donor HLA who is the potential donor. So now the technology has advanced so much that our outcomes in transplant have improved. Longevity of a renal allograft has become 18 to 20 years because we have technology to monitor rejections, prevent rejections, and we have the ability to modulate the immunosuppression in such a way that no one is over immunosuppressed, no one is under immunosuppressed. So the risk of infections has become very low. So now let us look at the blood group incompatible transplantation. Now, when you have a blood group mismatch, it is very simple that you tell the patient, "Arey blood group match wala donor leke aao." that is every time not possible. So there are two options available to this patient. One is a blood group incompatible transplant, means you do a transplant with the wrong blood group, but in a scientific manner. Second is you find another pair who might have a same blood group as our recipient, but then it has to be an equal opposite exchange, which is known as a paired kidney exchange. So today I will try to focus on these two main topics as to who patients can go through incompatible transplantations, who should be placed on a paired kidney exchange. So blood group incompatible transplant was considered long time as a contraindication. In fact, when I came back to India in 2009, in Toronto, I had done a lot of blood group incompatible transplantations, but India was still naive to it. And only by 2013-14 did the blood group incompatible transplantation start in India. Who was the pioneer? Japan was the pioneer. Then America took it up. Then it has spread all over the world. And now it is successfully being carried out after a lot of protocol changes which have happened during the last 25 years. And why did this happen? Necessity is the mother of invention. There was a lot of deficiency of donors, especially in Japan. What used to happen is, I am saying 35% are mismatched. They used to find 60% of donors are blood group mismatched for whatever reason. So they could not leave their patients on dialysis. So Dr. Tanabe, who is the leader for the world in ABO incompatible transplantation, devised protocols, and they have been doing successful blood group incompatible transplantation since 25 to 30 years now. Then John Hopkins, Mayo Clinic, all these people picked up these protocols, slowly refined the protocols, and now we have fully refined protocols which make it very safe, which I will show you in a short time. So what do we see for a blood group incompatible transplant? So if you look at blood group A, everyone has anti-B. That is why if I give a blood transfusion of B blood group by mistake, this anti-B is going to attack and the patient will have a bad rejection or a reaction with the transfusion or a rejection with an allograft, which is wrongly matched on blood group. Similarly, blood group B will have anti-A antibodies in the plasma. Blood group AB will have no antibodies in the plasma. Hence, blood group AB recipient becomes a universal recipient because any blood group can give him or her. Blood group O, the most difficult, because they have both anti-A and anti-B. Now, this is all a common teaching from our medical colleges, that what antibody is present in what blood group patient. We have to use that same knowledge, and we have to understand that if I have to place a kidney in a patient of blood group A, a kidney of blood group B, if it has to go in A, I have to remove this anti-B. Otherwise, the anti-B antibodies are going to attack. So we have to understand scientifically this premise, that these are the antibodies, whether they are HLA antibodies against the tissue, whether they are blood group antibodies against the wrong blood group. If I remove those antibodies or I suppress the formation of these antibodies using medications, these antibody titers will be in a negligible level in our body. And when the kidney is placed or the liver is placed or the heart is placed inside the transplant patient, the antibodies are not present to attack the organ. So this is the basic premise science has brought up to do blood group incompatible transplants. So what is a desensitization process? So desensitization process usually will use mechanical removal of antibodies, means whatever antibodies are present in our circulation, we will do plasma exchange because all the antibodies are in the plasma. When you do a plasma exchange with a plasma filter, a normal plasma filter, it will remove all the antibodies which are there in the plasma, including the blood group antibodies. So it is like whatever is formed and circulating in the system is removed with the plasma. Now the body is not going to stop making the antibodies. So you have to give medications which will suppress the formation of these blood group related antibodies. That doesn't mean anyone's blood group is going to change or anything in the body is going to change. You still cannot give a wrong blood group transfusion. This is only to accommodate the incoming allograft, and that is only solid organ allografts which you can do. You cannot still do a bone marrow transplant or a blood transfusion against the blood. So you are going to give medications which are going to suppress the formation of these antibodies. You're going to do plasma exchange, and you're going to mechanically remove the antibodies. And once you are happy with the level of these antibodies, which I will tell you later how much we see and how we monitor, then we go ahead with the transplant. Post-transplant, we also monitor antibody titers. If at all they're going up, we might add 1 or 2 plasma exchanges. But usually what happens is that pre-transplant, when you do the desensitization process, it is enough to last till the graft accommodates itself. And then there is no problem lifelong. And you may even forget that this was an ABO incompatible transplant. So let us see what protocols were used. So when Dr. Tanabe started the blood group incompatible transplant, see in 1996, 1997, what happened was they thought that spleen was the center for all the immunological processes in the body. So they started doing splenectomies. Then they started doing plasma exchanges. So they would do plasma exchange with the premise to remove the antibodies. So if you see this, minus 28 days. So if you are going to do a transplant here, this is day 0, means you're going to do a transplant here. You count minus 28 days. You start plasma exchange. You monitor the anti-blood group titer in the blood bank. You keep doing plasma exchange. And then when there is day 0, you will do a splenectomy along with the transplant. And after that, you will give all your regular immunosuppression. And the critical period is 0 to 1 week. This is where you can use anti-lymphocyte globulin, you can use all the induction agents to see that here the kidney does not reject. And then after that, it is a stable period. Now, this was used for quite a lot of time, but the only problem seen with this was a major surgery like splenectomy, which was being added to a recipient who is already sick. Splenectomies have led to bleeding post-transplant, clips have slipped away, there have been bleeding, patients have died with splenectomy. So, over time, people have tried to get away with splenectomy, and then slowly evolution of protocols came where they thought, let us try to avoid splenectomy and use medications and only plasma exchange. So next came this phase where minus 28 days, they would start the immunosuppression. Say I want to do the transplant on 1st of March. I would try to do from 1st of February, February having 28 days. I will count 28 days before the transplant. I will start medications from that time. I will start giving plasma exchange. Before I start doing all those things, I will do the titers. Now, how does a blood group titer look like? So blood group titer will look like 1 in 2, 1 in 4, 1 in 6. This is how the titers come. And the usual titers we want at transplantation is 1 in 8 and below. Now there are centers all over the world who accept 1 in 32 and go ahead. Like in Delhi, Dr. Vijay Kher's group will do at 1 in 32. Our group will do at 1 in 16 and just go ahead. Suppose someone presents only with a titer of 1 in 16. We will do none of these. We'll go for transplant directly. So this has been the experience which has evolved. So this was the middle protocol where they would give an anti-CD20, that means a rituximab, which is an anti-CD20 drug at minus 28. Then they would do plasma exchange from minus 14 days, that is 2 weeks prior to transplant. Again, they will give an anti-CD20, that means second dose of rituximab 1 day prior to transplantation. And then the transplantation would happen with the regular immunosuppression which we use for normal transplant patients. If the patient was sensitized and a higher risk of rejection from other reasons, they would use anti-thymocyte globulin. So this is what was used for the middle era. Then came the era of further improvement where immunosuppression was reduced even further. See, initially everyone was scared of going across blood groups. So they were using bombs. They were like splenectomy Cardalo, Ritux Dedalo, anti-thymoglobulin, because everyone was scared. Slowly, I would say the courage has increased because confidence has come with the outcomes, that because the outcomes are good, let us try and keep reducing the immunosuppression, because excessive immunosuppression is not good for anyone. So this protocol which I have shown you is from the middle era, say from the period of 2000 to 2010. Then the refined protocol over period of time, and the last 10 years, the world has been using this, and we also are using this protocol, that you use Ritux 1 week to 10 days prior, and you use only 200 mg. You don't even use bigger doses like 375 mg. Now, what does Ritux do? It is an anti-CD20 antibody, and it suppresses the B cells to produce the blood group antibodies. So it is like an immunosuppression which will help for transplant also. Then you give plasma exchange and you target a titer of 1 in 8. At the transplant, you might want to give basiliximab or ATG depending on the rejection risk of the patient, not from blood group, but from the HLA antibodies, which I pointed out earlier. That is why I had to give you that base. Once the transplant is done, you repeat the titers every day. If you see that the titer is rising, but the creatinine is stable, you do nothing. And we have had multiple patients where the titers did rise, but we have done nothing and the kidney has accommodated very well. If you see the creatinine going up a little bit and the titers are high, we would initiate a plasma exchange, 2 or 3 plasma exchanges, and the patient would settle down. Now, what are the titers which would make us worried? So if you have a titer of more than 1 in 1000, now I have written 1 in 512 here, but this is because if I have a 512 and above titers, I will use special columns for plasma exchange. These are adsorbing columns. So when the blood flows through these columns, it is like a plasma filter, but it is a special column which will have anti-A, anti-B, so or anti-A and anti-B. Because you have blood group antibodies in your blood, they will be adsorbed in the filters and your titer will come down very fast. These are costly and these are indicated only when your blood group titers are more than 500 or 1000 or 2000. Now a caveat here. If the titers are more than 2000, we try to avoid a blood group incompatible transplant and we try to get a donor who is matched in blood group with the patient, because till 1 in 1000, till 1 in 2000, you can manage with these filters and you can get. Now, what about the cost? Because everyone must be wondering that these are all hi-fi things. How much is the cost? So with a standard blood group incompatible transplant, the plasma exchange and Ritux are the only 2 things which are added, and they may add the cost of 2 to 2.5 lakhs, because 5 plasma exchanges, 1 rituximab will cost not more than this. So if a renal transplant is costing someone 10 to 12 lakhs, I can safely say in 13 to 14 lakhs, an ABO incompatible transplant can be completed. If the blood group titers are very high, that is more than 500, and we are using a glycosorb or an immunoadsorption filter, then the cost increases more, and that is the time when you have to think of giving a second option to the patient, that okay, we can think of a second donor or a donor from a paired exchange who can give you an equal blood group kidney. Because the titers are high, your cost might increase, plus minus the titers are extremely high, they may not come down. But there are patients who at 1 in 2000 we do glycosorb because they will want their own donors to give, and we go through it safely. So let us look at this case, one of the many ABO. Now we have completed more than 150 ABO incompatible transplants. Young lady, chronic kidney disease, 3 to 4 years, gradually progressed to chronic kidney disease stage 4. We counseled her for transplantation versus dialysis. She opted for transplantation preemptively, saying, I do not want to go on dialysis. Mother came forward as a possible donor. She was medically fit, but the blood group was mismatched. The patient was O and the donor was A. Now, the titer of anti-A, because see, in blood group O, I will look at antibody to A. The patient will have anti-A and anti-B both, but the donor is A. So I have to see how much is the anti-A in this patient, and it was 128 only. We initiated plasma exchange 2 weeks prior to transplantation after the rituximab, like I showed you the protocol. At 2 weeks, the patient underwent a successful renal transplant, and this is from 2017. Why did I choose this case? Because it is still today that she maintains a creatinine of 0.7. She was discharged on day 10. So this is as simple as it can get, and this is how 99% of patients of ABO incompatibles go out. What is the world survival rate? So patient survival with ABO incompatible kidney transplantation in United States and in India, we have now data from India also, which is now being published, and we have equal survivals. Now there are papers from JASN and everywhere where they say they might be mildly inferior to the blood group compatible, but it is definitely better than remaining on dialysis. And the survival advantage of transplantation comes in when you do a transplant, whether it is blood group compatible or incompatible. So overall, this is a very good choice if we have a blood group incompatible donor. Now let us look at paired exchange. So blood group incompatible, I showed you how we approach the patient, what are the options we have, what are the protocols we follow. And I've made it extremely simple as I would do in my day-to-day life practice. Now let us look at paired exchange. Now you have a family where you have a patient who is blood group B. The patient's donor is blood group A. Now, obviously, A giving to B, meaning I will have to do an incompatible transplantation, which I'm okay to do. But suppose the anti-A titer is more than 2000. It is going to cost a little bit more, plus it is going to take a longer time to desensitize, and you might land up with having higher titers and a little more complications because you have to do more plasma exchanges. So I would then tell, okay, we should think of a paired kidney exchange and find a pair where the patient is A and the donor is B. So the blood group of the second donor is B, which matches with the first patient. So that's donor will give to our patient. Our patient's donor, who is blood group A, will give to the second patient. Now, as you would imagine, it is not so easy to find such pairs who are equal and opposite. It's just not, it's like finding needle in a haystack. So let's see a case. 38-year-old male on dialysis since 2010. Now, this is also a very old case, and I'm deliberately picking up very old cases because their life expectancy is seen in their outcomes. Wife was a suitable donor, but the blood group match was not there. Patient was B, wife was A. Given options of transplant across barriers or paired exchange. Now, their titers were not high, but they were being financed by some company and their limit was not more than 10 to 12 lakhs. So they said, we will wait for some time. If we don't come across a pair, we will put in money and go for the ABO incompatible transplant. This was the discussion in 2010. He waited for some time, and in my OPD, I got one more patient who was also looking for a similar issue. 39-year-old male on maintenance dialysis in Gujarat since 2007, medically fit for transplant. So imagine this patient was on dialysis for 3 years, 4 years, and the first patient who was my primary patient was on dialysis since 2010 and had still waited for a year till this patient came by. Medically fit for transplant, wife was a suitable donor, but there was a blood group mismatch. Now, luckily, this patient was A and his wife's blood group was B. Patient had approached us just to search for any suitable match because he also did not want to go through blood group incompatible transplantation. Now, in 2010, we were experienced in blood group incompatible transplantation, but patients were very scared because in India, there was not much experience which they could see in blood group incompatible. So people were very reluctant to go through it. So what did we do? The first patient, B negative, second patient's donor, Mrs. DS, B positive, gave to the first patient. Our first patient's donor, whose wife was A positive, gave to the second donor. So that means that we could successfully do a match. What else had to be done? 2 NOCs had to be obtained, one from Gujarat, one from Maharashtra. So 2 committee meetings happened for permission because it was a swap transplant. You have to have one NOC in Gujarat and one NOC. So one patient was in Gujarat and one was from Maharashtra. So the paperwork took around 2-3 months or more because in between Diwali came and Christmas came and there were holidays and the government papers were being delayed. So, you know, when 2 families and swap is involved, sometimes the paperwork takes a little more time is what we have to also understand. So there, if the blood group mismatch match would not happen, then I would have to go for an incompatible transplantation. But luckily, after my patient's 1 year of wait, he did get. Now, everyone is not that lucky. Now, let us look at another case. 51-year-old lady who was suffering from end-stage kidney disease and was on maintenance dialysis for 3 years presented to my outpatient department in 2017. Inability to get transplant due to positive cross-match. Now, this is a different issue which the patient was facing. Now, her blood group and her husband's blood group were both O positive, but the husband still could not donate to her because the tissue cross-match was coming positive. Why would the tissue cross-match come positive? This patient had received donor-directed transfusion. Now, this is something I want all family physicians, all our colleagues to understand that, you know, sometimes patients are told that, "Arey, aapke family mein se hi blood le lo, bahar se blood mat lo." Now, what happens is that in such patients on dialysis, if the family member has given blood, you are actively telling the body you make antibodies against this person who is giving you blood. So इसमें यही हुआ कि the patient's husband gave blood to the wife when the dialysis was starting, and what happened was that the patient formed so many antibodies towards her husband and common antigens in the population कि she was not getting any person who could give her a kidney despite having a matched donor and everything. She was stuck. 4 years she was on dialysis. Issues here, she was blood group matched, but she had HLA antibodies to the tissue, which I told you in the beginning. So, transplantation with these antibodies, how do you go about it? So, we have to acknowledge that there are antibodies and we have to tackle them. Like when we have a blood group mismatch and we say that, okay, the blood group is mismatched, let me handle it. Similarly, when you have antibodies, you don't neglect them, you don't hide, you just face them. But the issue is that if I go to transplant them, कि अरे blood group तो matched है, it is easy, cross match को negative करते हैं और जाते हैं. That is why what many people try to do. But what happens is you do plasma exchange, you give rituximab, you do all this what you do in blood group incompatible, because that is a basic premise to remove antibodies. It will work for the first few months or first few weeks. But unlike blood group antibodies, these HLA antibodies will come back, and they will cause a chronic allograft dysfunction. And in our country, this becomes very difficult because the cost of maintaining the transplant, cost of doing the transplant increases when you have these type of antibodies. So what do you do with these people? You try to find donors with a paired exchange so that you give such a donor to the patient against whom you don't have antibodies. So if everyone understands this, ki blood group mismatch hai, you are trying to find a pair with whom your blood group matches. Similarly, when you have a tissue mismatch, you are trying to find a donor against whom this patient does not have antibodies, so that we don't have to do all this plasma exchange and all these things. It is more relevant for HLA antibodies than to blood group incompatible transplantations, because blood group incompatible transplantations, the initial 15-20 days are important, after which the blood group mismatch does not matter. But in HLA mismatch, this will matter because lifelong the kidney is going to face these antibodies and we might end up with a short kidney life. So again, the same desensitization is what sometimes it was followed, but then later on, the option of a living donor paired exchange, meaning a swap transplant, came up in the Western countries because they realized that they were spending a lot of economy on these sensitized patients by trying to remove HLA antibodies. So unlike ABO incompatible transplant, where it is a go for a mismatched transplant, here the situation changes. Because there are reports which are saying that if you go ahead with a transplant, when you already have antibodies against the donor, your outcome is going to be poor. So that is why now the world is changing the strategies, that if you have HLA antibodies, you try not to go for these desensitization protocols, but you try to get a matched donor or an acceptably mismatched donor. So what was done for this patient? She was placed on our list for donor paired exchange. So we have a sensitized organ recipient registry, which we maintain for such specific patients. And after 2 years of wait, we could find a donor who was blood group mismatched, but HLA matched with the patient, and we could go ahead with the transplant. So this is how it was done. So Mrs. SR and Mr. SR is the donor, who's the husband of our patient Mrs. RR, and this patient had positive cross match and had antibodies against an antigen B50, B35 in the patient's husband. And there was another pair, recipient Mr. SM and donor Mrs. KM. Now they were basically only blood group incompatible, and they were not rich enough to afford an incompatible transplant. They had only limited funds of 8 to 10 lakhs which they wanted to spend for transplant. So they said that if possible, please do a compatible. And luckily, this donor's HLA was acceptable to this patient. So we could give a transplant, this donor's kidney, to our recipient Mrs. RR, and Mrs. RR's husband Mr. SR gave his kidney to this recipient Mr. SM. Now if you see, Mr. SR is O positive, gave to Mr. SM who is O positive, but Mrs. KM is A positive, she gave to O positive apna first patient. Now here a blood group mismatch was acceptable because HLA antibodies are more dangerous than blood group incompatible transplant. So this is the difference, how you use paired exchange, how you use a swap transplant to your benefit. So this was the first of its kind in India, and it was reported in the media and in the scientific papers that for India, this was the first of its kind. Abroad, this is a routine which is done for all patients who are in a similar situation. So now let us look a little bit on how swap exchanges work and what is the logistic behind it and how do we make pairs. So there are simultaneous, so if I have 3 pairs which I have made, or if I have made 2 pairs, for example, these 2 patients, I had to have 4 OTs running together. Both the donors induced together, both the recipients induced together, because what if first one says ki, "Arey now mera to ho gaya, abhi mujhe nahi dena hai." That can happen. Reneging it is called. So that is why every OT has to be simultaneous, all the 4. Both the donors, both the recipients have to be induced in anesthesia together, and the kidneys have to be given to the respective recipient, and we actually have to label the OTs properly so that there is no mix. It is very satisfying because you work hard and you see the results. We have to make equal pairs. You cannot say that one will get an older donor, one will get a inferior donor. So you have to see that both the donors and both the recipients get equal justice. One pair cannot suffer and pair cannot get a better option. So what are the examples of change? Sometimes you can make 2 pairs, sometimes you can make 3 pairs. Like for example, an incompatible pair A giving to B, B giving to C, and C donor giving to A. So this can happen. Then there may be pairs where you have 6 people together and you are having 6 transplants happening together, and that has happened abroad, that they have 12 to 15 OTs working together when you have big chains of pairs which have been done. Then there is something known as a non-directed donor which starts the chain. So a non-directed donor is, abroad this works, in India it may not work because we do not still have altruistic donation in place. So you have a non-directed donor giving to the first recipient. The donor of first recipient gives to recipient 2. The donor of second recipient gives to recipient 3. And the first and donor 3 is waiting on the list. So this is how the chain keeps going on. So this is known as a domino chain. So it is like multiple transplants, like a cascade, one giving to second, second giving to third, third giving to fourth, and you can get at least 25 to 30 pairs made together with just one person who is just an altruistic donor. So this can be done abroad, and they have softwares wherein you can put the donor HLA, you can put the donor blood groups, you can put the recipient blood groups and the donor HLA, and they will find compatible pairs from the softwares. Now, what about the softwares in India? So yes, have registries in our country. Astra is a registry made by Apex Group in Mumbai, and they have used IIT knowledge, and IIT students and IIT Mumbai has made this Astra possible. And Astra was mainly made just for blood groups, but not for HLA. We made a sorter registry and a MILAP registry, wherein when I key in the HLA incompatibilities of a recipient and the blood group, I will get a compatible donor, and I can inform that doctor that, oh, your patient has got this suitable match, and if interested, we can go ahead with the swap. IKDRC in Ahmedabad, so Institute of Kidney Diseases Civil Hospital in Ahmedabad, uses an American software to max the pairs. So they have maximum number of ABO compatible pairs which they have done, and they lead in that. They have taken that alliance software. Now that alliance software still does not add to the HLA match. So our Indian software has to take our cultural Asian HLA antigens. That is why American software will never work for us. So hopefully the sorter registry takes it ahead and helps more patients. So last two slides to finish the talk. So if I have a kidney candidate who has a living donor available and has an HLA ABO compatible donor, you go ahead with the transplant. If you do not have an available donor, you will wait for a cadaver transplant. Now, suppose the patient is not compatible, then you register with kidney paired exchange programs like the Astra or the Sorter or the Kidney Paired Alliance. There will be match runs which will be done every few days, and we will try to find a match. In what manner? Blood group and HLA. So if someone has antibodies like our patient had, we will have to also look at the HLA match. So there you can choose that. Now, if no match is found and the patient is waiting for a long time on dialysis, it is risky. So then you might have to put the option of desensitization to the original donor. If you find a compatible pair and there's a high strength, then you just proceed for the kidney paired exchange. So this is how we will look at our patient, that we want to do the best for our patient. We don't want to leave them on dialysis for long. So either an incompatible or a paired exchange. This becomes the best options for these kind of patients. So to summarize, kidney transplantation remains the best modality of treatment of end-stage kidney disease. But like Dr. Ravindra said, we have to prevent kidney diseases. But once they reach end-stage, we have to work hard to get them off dialysis. ABO incompatible transplant is safe and feasible with very good outcomes. Paired exchange option is to be put forth only if we have high titers to start with, and it is going to be costlier to give them those titers. Next, if you are sensitized with HLA antibodies, then it decreases the probability of a patient to undergo transplantation. So desensitization protocols are very risky for these people. The outcomes are not very acceptable, and they might make the patient prone for infections in the future because of the burden of immunosuppression. Here, a paired exchange is always a better action. So ABO incompatible, a good option, a feasible option, safe option. But HLA incompatibility, paired exchange becomes the first option and desensitization becomes the second option. I end over there. Thank you for your patient listening.
Thank you, Dr. Tapiawala. You are always excellent as usual. And we had many lectures with you with IMA. Maybe since the lecture was very elaborative, there are not many questions.
I hope I have not gone too much on the higher level. I tried to because transplant immunology becomes very complicated sometimes.
Yeah. There are a few questions, madam. The preventive tips for early diagnosed CKD cases.
Can you suggest preventive tips? I think this question is for Ravindra, but is Ravindra there?
It has come late.
Okay, I can answer that.
I will take your question, madam. Reversal treatment for unmatched high-risk cases with stem cell therapy.
So stem cell therapy has been tried earlier in IKDRC itself. Dr. H.L. Trivedi was a pioneer in this. He passed away 3 years ago. But he did a lot of thymic cell implants, stem cell implants. But over time, it has been realized that these therapies are not working for transplantation. So for now, we do not have any evidence that these work. And no matter what you do, the immunosuppression which is going to be required is going to be required.
Can you elaborate on preventive tips? I mean, if a person has
So
diagnosed
a
as
chronic
CKD,
kidney disease, a chronic kidney disease is like a modifiable factor which we all can practice in our day-to-day life. So if there is a patient who has a risk factor, say the patient is obese, the patient has a family history of renal failure, the family history of diabetes, hypertension, patient is diabetic hypertensive. These are high risk to have kidney failures. So what will we say? We will tell the patient that maintain a regular healthy lifestyle. Now, thankfully with COVID, people have gone into exercise habits. People have stopped eating outside because of the lockdown. So their habits did improve transiently. But then Swiggy and Zomato took it over. So processed foods and junk foods have still continued. So we have to advise them that junk food, processed food is not good for anyone, for you also, for me also. Low salt diet is good for everyone. And people always want to ask which salt is good, because Indian population believes that sendha namak or black salt is excellent. But no, black salt is very high in sodium. Black salt is very high in potassium. This is not good for us. So I would say in today's day and world, Tata Light Salt or Tata Super Light is the best, because the lowest amount of sodium per gram of NaCl is present in that. So that is about salt. BMIs. So if we maintain our BMI to 18 to 20 with regular exercises and a good diet full of fresh vegetables and fruits, we will be able to prevent lifestyle related disease. Avoid a sedentary lifestyle. So if at all we are sitting in a lockdown situation, try to walk as much as possible. In fact, I tell people, you use staircases of your apartments to do exercise because your gyms are closed, you can't go down. Don't be sedentary. Luckily for us doctors, we are on the move, so we are lucky that we can go anywhere anytime. But for people who are at home, working from home, sedentary lifestyle should stop, even for elderly people. Then target blood pressures. Now this is very important. Target blood pressures should be 120 to 130 by 70 to 80, irrespective of the age, irrespective of the disease. Because I hear patients saying that if the blood pressure is 150 by 150 or 160, nahi, wo hamare age ke hisab se theek hai. No, it is not okay. JNC says that a target BP of 120 to 130 is absolutely necessary to prevent target organ damage. So we have to adhere to that. By hook or by crook, get it to 120 by to 130. Agents are not important. What you use is not important. Lifestyle diseases, salt restriction, and antihypertensives. Try to get the BP in the target. HbA1c of 5 to 6 is important, and a random blood sugar of 70 to 110. So these are absolutely necessary. And we have to see that we tell the patients to quit smoking, because that also sometimes lead to a lot of CKDs. So basically, stop unprocessed food, low salt diet, target BP, target diabetes. High risk population, you might want to monitor with urine microalbumin creat ratio, because this will be the first pickup of a kidney disease coming, and you can quickly reverse it. Now you have DAPA trials showing that SGLT2 blockers are good for heart, for kidneys, for diabetes. So you have a lot of armamentarium at your footstep that you can use so much to prevent kidney diseases.
Thank you very much, Dr. Shruti. It was a really important message as far as the World Kidney Day is concerned. I'll just end up with the last question. What is the role of ozone therapy in CKD?
Not much, no evidence.
Okay.
Prevention,
Okay.
prevention. Nothing works better than that.
Okay. Thanks a lot.
Can I
Thanks
ask
a
one
lot.
question?
Yeah.
Can a failed kidney work again?
Can a dead man come alive?
Failed.
If it is an
Very well
acute
answered,
kidney
madam.
injury,
Very well answered.
if it is an acute kidney injury, yes, a failed kidney will improve when it is acute kidney injury. But if something is dead because of CKD and that is failed, it will never come alive. Not with stem cells, not with ozone, not with Ramdev Baba, not with all these kadas and all people drink. Dead man को अगर ये सब पिलाएंगे उठेगा क्या? I always ask the patient कि you look at a dead body in front of you and you say चलो काढ़ा पिलाते हैं, चलो ओजोन थेरेपी देते हैं, चलो स्टेम सेल देते हैं, कोई उठने वाला नहीं है.
Very nice.
हम लोग तो उसको सिर्फ सर्टिफिकेट दे देते हैं.
Correct, that's what I'm saying.
Okay.
Okay.
Thank you very much, Dr. Tapiawala, and we are extremely grateful for your presence almost on every World Kidney Day.
No,
Thanks
no,
a lot.
I enjoy everyone's company. In fact, I'm missing the meetings in IMA. In fact,
Yes,
I
yes.
asked this time, why have you not kept hybrid COVID? तो है नहीं अभी.
Yeah. We'll meet next year, madam.
Maybe.
Yes.
Yeah,
Chalo.
definitely.
Yeah. Okay. And now we move on to from nephrology we now move on to oncology, and we have another very great speaker, Dr. Advaita Gore. And to introduce Dr. Gore, I invite Dr. Kajal Ahuja, and Kajal will introduce Dr. Advait Gore.
She is just assistant secretary. I am a CGP just now.
Yeah. Sorry.
Dr. Advaita Gore is a consultant medical and pediatric oncologist, hemato-oncologist, and BMT physician. He is Associate Director, Department of Medical Oncology at Nanavati Max Super Specialty Hospital and Zen Multi-Specialty Hospital, Mumbai. He is Executive Editor, Indian Journal of Cancer. He has done advanced training in hemato-oncology at UKGM, Germany. He has done DNB in medical oncology and general medicine. He has done certification course by European Society of Medical Oncology, ESMO. He has done teaching and assessing DNB medical oncology super specialty students. He has done peer-reviewed articles for Indian Journal of Cancer, Journal of Cancer Research and Therapeutics, Indian Journal of Radiology and Imaging. He is advisor for development of healthcare-related apps like Vital and Uhapo. Today, he'll be speaking on early diagnosis and management of colorectal cancer. Over to Dr. Advaita Gore.
Thank you, Dr. Kajal, and thank you, Dr. Anil, and the entire IMA team for having me here. I'll just share my slides. So in the half an hour which has been that we have to discuss about a very vast topic, I would try to be brief to give you certain pearls as to how we as oncologists look at colorectal cancer management and looking towards an early diagnosis and treatment for our patients. So the contents of my talk would essentially involve on these 4 points. One is the early diagnosis, where I would touch upon the risk factors and the screening, treatment for the operable colorectal cancer. The third point would include about the advances in metastatic colorectal cancer and certain updates in the management. So this is the WHO Globocan data in India, where we see that colorectal cancer is the fifth most commonest cancer when we look at both the sexes together. In females, it is the fifth common cancer, while in males, it is the fourth common cancer. And totally, we see the number in 2020 is roughly about 65,300 colorectal cancer patients every year, which forms about 5% of the total cancer burden in India. The early diagnosis of colorectal cancer has been a very, very imperative thing, especially in the Western countries where there are definitive screening programs. And we as oncologists do feel that these screening programs should also be implemented in India, and there is a lot of advocacy going on about it. In terms of signs and symptoms, these are the common signs and symptoms which all of us know, that a persistent change in bowel habits, which may include alternating diarrhea or constipation, or a sudden change in stool consistency, is the most commonest presentation that these patients have. Patients do also present with bleeding per rectum or frank blood in stools. It may be hematochezia or it may be just frank blood. There can be persistent abdominal discomfort like cramps, gas, or pain, but however, this symptom is seen in less than 10% of patients. Most commonly, rectal tumor patients do present with a sensation that the bowel doesn't feel as if it is evacuated completely, and this is a very common symptom which is seen in practice, which definitely needs to be evaluated. Fatigue, weakness, weight loss are other symptoms which are related to the disease, which may indicate towards general debility of these patients. So when we look at risk factors for development of colorectal cancer, they can broadly be divided into non-modifiable risk factors, which basically looks into age greater than 50 years, male gender, ethnicity, patients who are having a family history of colorectal cancer or colorectal polyps, or history of inflammatory bowel disease and certain genetic syndrome like Lynch syndrome or familial adiposis coli, and patients with type 2 diabetes. There are certain modifiable risk factors which include smoking, alcohol consumption, high consumption of red meats and processed foods, low intake of fruits and vegetables. Patients who are obese have increased body fat and physical inactivity. Now, generally, when it comes to evaluation of these patients and decide about screening of these patients, the whole purpose of risk stratification is to actually decide how frequently the screening tests are to be done for this subgroup. So patients are divided into three groups: average risk, increased risk, and highest risk. In average risk, this includes patients who are aged more than 50 years, those who do not have any history of adenoma or inflammatory bowel disease, or any family history of colon cancer. Patients who belong to the increased risk group are the ones who have a personal history of adenoma or colorectal cancer, or personal history of endometrial or ovarian cancer prior to the age of 60, personal history of inflammatory bowel disease, family history of colorectal cancer or adenoma, and family history of HNPCC. The highest risk group is patients who have history of colon cancer in family members, those who are younger than 50 years of age. There is a family history of polyposis and a personal history of polyposis syndrome with a personal history of HNPCC also. Most of the individuals should begin screening for colorectal cancer after turning 50 and then get continued screening at a regular interval. Earlier than 50 years of age, the screen is recommended only if an individual or a close relative has a colorectal polyp or colorectal cancer, or there is history of inflammatory bowel disease or genetic syndromes like FAP or HNPCC. The most commonest and the most performed GI procedure is colonoscopy, and it not only allows for early detection of cancers but also helps in removal of polyps and long-term protection from colorectal incidence. There have been multiple reviews which have shown that there is a 68% to 69% risk reduction in colorectal mortality associated with screening colonoscopy. Stool-based testing has been evaluated in very large randomized trials. Once in 6 months screening after 13, 20 and 30 years of follow-up did correspond to about 18 to 20% reduction in colorectal cancer monitoring. The fecal occult blood testing also reported a reduction in about 20% in colorectal cancer incidence. There are newer tests which as FIT, which is the immunohistochemical test, and certain newer tests which are available which have increased sensitivity for testing. However, as of today, those tests are not available in India. So a GUAC fecal occult blood is the one which should be asked for. Sigmoidoscopy also does allow evaluation of the left side of colon. If it does require lesser preparation than colonoscopy. However, patients who are detected with any lesion in the sigmoid should undergo a completion colonoscopy to look for skip lesions or other lesions which may be there in the proximal part of the colon. When we look at performance of these colorectal screening tests, colonoscopy does give a 100% detection rate, flexible sigmoidoscopy about 90 to 100% mainly for the distal colon, but not for proximal colon. There are certain software-based tests which are CT colonography, which can be done like a virtual colonoscopy, which is also being evaluated as a good screening tool. It is lesser invasive than colonoscopy, does not require sedation, but any positive result on a CT colonography needs to be confirmed with a colonoscopy and also needs a biopsy later on. So these are the current guidelines for screening patients who are at average risk. If they have age of more than 45, there's no history of adenoma, no history of inflammatory bowel disease, they need to undergo colonoscopy once. If there are no polyps, rescreen with any modality at 10 years. If there is polyp, then based on the histopath of the polypectomy, whether it is hyperplastic or it is adenomas, the rescreening is planned. Stool-based testing is the GUAC-based testing, if which is positive, colonoscopy is followed, and then the pathway as described above should be done, or flexible sigmoidoscopy or CT colonoscopy should be done. So a colonoscopy is recommended currently every 10 years, has a 95% sensitivity for detecting colorectal cancer. CT colonoscopy every 5 years with again a similar kind of sensitivity, and the GUAC based blood test should be done annually, which has roughly between 65 to 80% sensitivity to detect colorectal cancer. Coming to the treatment of operable colon cancer, it's very important that a proper staging evaluation is done, a proper physical examination to evaluate for any sites of clinically detectable metastasis, especially hepatomegaly and ascites needs to be clinically evaluated. Colonoscopy and biopsy does remain the initial test to get a tissue sample, because tissue is very important to get molecular testing done later on if required. A CT scan chest, abdomen, pelvis, and I say chest also, especially in left-sided and rectal tumors, because we've seen many a times that due to the surgical anatomy of the rectum, these patients may not actually develop any abdominal nodes or liver metastasis, and they may directly have lung metastasis in about 15% of patients. So especially in left-sided colon cancer or rectal cancers, a CT scan chest is essential. MRI is a good tool to decide therapy, whether these patients need to undergo pre-operative chemoradiation based on the circumferential margin, because rectum is like a cylinder and we look at a circumferential margin for rectal tumors. PET CT scan does not have a role at diagnosis. The CT scan gives us all the information which is required. However, it can be useful in certain situations, especially if patients who have been received treatment are on follow-up and have rising tumor markers, or patients have liver limited metastasis. To evaluate what is the extrahepatic disease, the PET scan may be useful and better results than CT scan can be found. Tumor markers like CEA are not useful for screening. It is to be used only in patients who have a biopsy proven positive colorectal cancer diagnosis, and it essentially is to prognosticate patients and to follow up if found elevated at diagnosis. So coming to the staging, broadly it is classified as stage 1 tumors which are T1, T2, stage 2 tumors which are T3 to T4 but node negative. Stage 3 tumors are the ones which are anywhere between T1 to T4b but having N1 to N2 lymph nodes. So any lymph node positive disease really makes it as third stage 3. And stage 4a and stage 4b are two categories in which the metastases are limited in M1a and they are potentially resectable, and M1b, these are the metastases which cannot be resected. Surgery does remain mainstay for all localized colon cancers. Neoadjuvant chemotherapy is considered for tumors which are invading local organs or tissues, and surgery most of the times would involve a colectomy with en bloc removal either in one stage, or a resection with diversion in case that the patient has presented with intestinal obstruction, and then doing a complete resection at a later date once the patient's abdomen is settled. Mainstay for post surgery treatment essentially is based on the stage. We come to stage 1 disease where there is a chances of recurrence is estimated to be less than 10% at 5 years. However, patients who have T2 stage, those who have lymphovascular invasion, those with low rectal lesions or poorly differentiated cancers, and in male patients, they do have a higher risk of recurrence. But in spite of these high risk factors, still currently there are no guidelines which recommend that chemotherapy is beneficial in stage 1 colon cancer, and all of these patients are kept in observation after completion of surgery. There is certain role for using aspirin and vitamin D and making these patients aware that physical exercise does decrease the recurrence. In stage 2 disease, when we look at the 5-year survival in stage 2 colorectal cancer, it is estimated to be about 81%. There are certain high risk features again, which are lymphovascular invasion, perineural invasion, obstruction or perforation at presentation, less than 12 lymph nodes which are examined or removed at the time of surgery or examined by the histopathologist, and indeterminate or positive margins. There is also a marker called microsatellite instability, MSI high. If MSI is high, this is a good prognostic marker and it indicates that chemotherapy is going to have a poor response in these patients. So patients with stage 2 disease having MSI high are not given chemotherapy, they are kept in observation, while those who are having MSI low or microsatellite stable tumors, they are considered for chemotherapy. There are certain genomic assays which are available, colon print and oncotype, which do predict the risk of recurrence, but as of today, they do not predict the benefit of post-operative chemotherapy. Hence, they are not used in regular clinical practice unless it's a part of a clinical trial. A CEA level is the most important parameter to actually monitor these patients, and it really helps if the CEA level is high initially, then goes down post therapy, and then these patients are on every 3 to 6 monthly CEA monitoring it for first 2 years, and then every 6 monthly for a total of 5 years. In stage 3 patients, they do have a 5-year survival of about 60%. There have been multiple trials, historically 5-FU levamisole, then 5-FU leucovorin given bolus, then 5-FU infusion came into the picture. Treatment was initially 12 months, now it has come down to 6 months, then further to 3 months also, and the injectable option of Folfox versus oral and IV combination of Capox. These are the two most preferred regimens here. This is on basis of these Mosaic and SABP-C07 study, where we found that in patients who were given oxaliplatin based chemotherapy, there was a 7% improvement in survival as compared to giving only 5-FU. However, oxaliplatin does need to be used carefully in patients who are more than 70 years of age, because that survival benefit has not been shown. Currently, there is no trial which has actually compared Capox versus Folfox. The dose of oxaliplatin in Capox is higher, but in Folfox, the total cumulative dose of oxaliplatin goes much higher. So there is no further data which has actually shown that there is benefit of addition of any biological or targeted treatments in post-operative setting, where patients have been given these agents like bevacizumab or cetuximab or the EGFR agents in a post-operative setting. Now, further de-escalating therapy from 6 months to 3 months is also possible. This is what the IDEA meta-analysis showed, that in select group of patients, when we look at stage 3 disease, they can be divided into low risk stage 3 and high risk stage 3. Patients with low risk stage 3 can be treated with 3 months of Capox, which was equivalent to 6 months of Capox, but patients with high risk stage 3, the 3 months of Folfox is not superior to 6 months, and there the 6 months therapy needs to be given. Now, coming to the last part, this is about metastatic colorectal cancer. The current paradigms which look at having some patients with limited stage 4 disease still can be cured using a multidisciplinary team approach. There definitely is a role of addition of biological therapy to chemotherapy in stage 4 metastatic colorectal cancer, and this has improved outcomes. There are multiple studies which have identified molecular predictive factors, which is helping individualization of treatment, and there is also an expanding role of immunotherapy in these patients in metastatic colorectal cancer. So when we look at a patient with metastatic colon cancer, these are the different factors which actually influence my treatment choice. We look at patient characters, the comorbidities, age, what is the prior treatment, the molecular characters in terms of RAS, RAF, MSI status and HER2 status. Look at the tumor characteristics, where is the location of the tumor, how advanced the disease is there a potential for resectability, and looking at the patient preference with quality of life and the toxicity profile of the drug, trying to balance out what each individual patient needs. So biomarker testing in colorectal cancer actually has moved a long way. For all colorectal cancers, today I will ask for MMR, which is the mismatch repair protein evaluation, and the microsatellite stability. For metastatic disease, along with MMR and MSI, I would ask for the RAS, RAF, HER2 and the NTRK, because we see here that almost 45% of patients can be RAS mutant, about 26% can be wild type where the anti-EGFR therapy can be used. There are about 7 to 8% of patients who may turn out to be MSI or POL mutant where there is role for immunotherapy. So the current guidelines do recommend that there is no need for doing a multi-gene testing. However, if it is necessary because a patient has other high-risk genetic factors, in those situations only we would recommend. Otherwise, on most of the patients, we would recommend getting only a hotspot mutation study to decide what therapy of choice can be given. So metastatic colorectal cancer actually is more than one disease, and currently there is a new classification, a molecular classification for colorectal cancer, which is currently underway, and we are awaiting that publication, the results to be peer reviewed to actually come to a consensus about molecularly classifying colon cancer. We can classify this on a molecular level as MSI high versus MSI low. HER2 positive colorectal cancer behaves in a different way. RAS wild type and RAS mutant, and BRAF wild type, BRAF mutant do behave in a different way. In terms of anatomical location, the stool flora types, and in young versus elderly also there are differences in colorectal cancer. We'll briefly touch on that. So the sidedness analysis actually looks at looking at what the unusual clinical course is. There is a peritoneal dominance in right-sided tumors. Mutations are not random. BRAF mutations are more common in the right-sided colorectal cancer, and this is a biologically heterogeneous organ. The right colon and the 2/3 of the transverse colon actually has a different molecular and embryonic origin as compared to the left colon and the distal 1/3 of the transverse colon. We see different molecular heterogenic types based on what the location of the tumor is. So there are commonly seen mutations with the RAS, KRAS, the HER2/neu, which are seen in the right-sided colon. The MSI can be high in the right-sided colon disease, while MSI is low or negative in patients with left-sided colon disease. This study also proved the point that patients should be exposed to all active and approved agents during treatment so as the survival increases with increased lines of therapy. So we see here that as the number of lines of therapy increased from 1 to 2 to 3, the median survival of patients also kept on increasing, with one line of therapy offering a survival of only about 12 months, with 3 or more lines of therapy improving the survival to about 26 months. So the general treatment algorithm for metastatic colorectal cancer is based on what the mutation status is and what sidedness. Patients with BRAF, RAS wild type, RAS are treated in one way using bevacizumab as an option with chemotherapy. We will come to those details. The RAS mutation, when we also look at bevacizumab. Patients who are MSI high or deficient MMR, we would be treating them with a drug called pembrolizumab, which is an immunotherapy. These are the various signal pathways through which tumor cells grow. EGFR is blocked by cetuximab and panitumumab. The VEGF, which is the vascular endothelial growth factor, is blocked by these three drugs: bevacizumab, ramucirumab, and aflibercept. So when we look at first-line therapy for a patient who's RAS mutated and microsatellite stable, we see that the outcomes with EGFR inhibitors, especially panitumumab, and chemotherapy in patients who are wild type as compared to mutant, we see the difference here that patients who are mutant KRAS actually perform poor with these agents. So we would not use these agents in patients who are having mutant RAS or BRAF. Bevacizumab is a better drug in these subgroup, and that is what the Maverick study showed, that giving addition of bevacizumab in patients who are RAS mutant, it does improve survival in patients who have RAS mutant as compared to giving the EGFR therapy. There is also a role of bevacizumab as a maintenance, where after initial completion of chemotherapy, there is a maintenance dosing for bevacizumab until disease progression, because bevacizumab, being a targeted treatment, does not carry all the side effects of chemotherapy. When these patients eventually progress, what is the option in second line, where we evaluate what is the prior treatment, what has been received, whether there has been progression on VEGF therapy, if VEGF therapy has been given for maintenance or not, and the other molecular subtypes. There has been a trial which looks at bevacizumab continuation beyond progression versus giving only chemotherapy, and that trial did show that continuing bevacizumab and chemotherapy together adds on improvement in survival. The other option is to change to aflibercept or ramucirumab, but we see here from these studies that the TML, VELOR and the RACE study, which have evaluated these three drugs in the same indication, one in continuing bevacizumab beyond progression or changing to aflibercept or changing to ramucirumab, actually doesn't make much of a difference. It entirely depends on how the patient toxicity profile is and how patient is tolerating the drug, that one would change the chemotherapy partner and offer this targeted therapy. In terms of RAS wild type and microsatellite stable, the anatomical site does matter. We see clearly here that bevacizumab works better with the right-sided disease as compared to the left-sided disease, and the cetuximab works better in the left-sided disease as compared to the right-sided disease. So currently, as of today, if a patient has a right colon primary with a stage 4 disease, I would not be using cetuximab for these patients. I would go for bevacizumab. The same was evaluated in a large study looking at bev versus cetuximab and chemotherapy. This is the survival based on tumor location. This is in wild type, in which the EGFR therapy is supposed to work, but we see here that in left-sided disease, cetuximab has a greater survival. In the right-sided disease, it's straight away cuts down to 1/3. So the treatment decision not only depends on the mutation, but also on the sidedness, and that is what the first line therapy decisions are going to be there. In terms of refractory disease, in second line, we can use these targeted treatments using panitumumab or cetuximab, and they both have shown that they can be given as single agent as well as combined with chemotherapy. In the second line, if we are using an anti-EGFR in first line, we can always use an anti-VEGF in second line, and the other way around also. Cetuximab, panitumumab may be interchangeable, and these patients need to undergo molecular testing to identify who's going to be benefited. Bevacizumab can be combined with chemotherapy irrespective of the sidedness, and it can be combined with a 3-drug regimen called FOLFIRINOX also in young fit patients where we are looking at a potential cure. Third line and beyond is very salvage, and where there is the role for oral regorafenib. These are oral VEGF targeted therapy. There is also a drug called TAS-102, which is called trifluridine tipiracil. This is available in India. These are simple oral tablets which can be given instead of prolonged infusional chemotherapy. There are additional biomarkers like BRAF mutations in colon cancer, which is seen in about 10% of patients. There are drugs which are available currently. Binimetinib and encorafenib both are available, and these are used. These have shown that they improve survival in this select group of patients. The HER2 amplification also is seen in about 13 to 30% patients in colon cancer, and these are the ones who do show response to trastuzumab, which is a drug which otherwise we use for breast or gastric cancer, and we are seeing that there are response rates of almost in 30% of patients. There is a role for combination for trastuzumab and the newer generation drug pertuzumab also, and also for an oral tablet called tucatinib, which can be used along with trastuzumab in these patients who have been heavily pretreated. We see great responses in more than 50% of the patients. There are newer antibody drug conjugates, which is a targeted chemotherapy delivery of sorts, in which TDX is used in metastatic colorectal cancer for targeted delivery of the chemotherapy agent directly into the HER2 overexpressing tumor cells. And there are multiple studies currently going on with again showing that there is a disease control rate of almost 83%, with a stable disease or a partial response seen in almost 50% of these patients who were on this DESTINY study. So in terms of biomarker driven therapy in colorectal cancer, we are moving towards personalization and individualization of treatment for metastatic colorectal cancer, improving outcomes. We do need biomarker analysis in all patients with metastatic colorectal cancer, and this requires good and expert knowledge for applying these findings to each individual. And the relevant markers which currently would look at are MSI high or MSS, RAS, BRAF, HER2, NTRK, and other alterations which would be part of broad molecular profiling. In terms of immunotherapy, these are the data for the pembrolizumab. This drug has been recently approved for metastatic colorectal cancer, which is MSI high. This is on based of this keynote 177, which actually has shown that a completely non-chemotherapy option for treatment in patients who are having MSI high is available. These are patients who are having inoperable disease, and we see that at 12 months, when we compare it to chemotherapy, only 38% patients are without progression as compared to 55% on immunotherapy. And at 3 years, with the chemotherapy arm patients, and where they had only 11% patients who were still continuing treatment as compared to almost 42% in patients who were on immunotherapy. The overall survival data also shows that there is a significance in terms of statistics, where 50% patients on chemotherapy are surviving at 3 years as compared to 61% patients those who are on immunotherapy. There is another drug, as I mentioned, that TAS-102 with bevacizumab versus the capecitabine, which is available, and this data also has shown that TAS-102 is a better drug than capecitabine when combined with bevacizumab. These two are the recent data, simple drugs, oral drugs to be given, showing good survival benefit in patients who are treated third line and beyond. So these are the conclusions, that these drugs do improve the progression-free survival, and I thank you for a patient listening.
Thank you very much for giving an excellent information. Sir, I have got one question. What is
Yeah,
the
madam.
survival rate of T3N1 colon cancer?
So T3N1 colon cancer would stratify as a low risk stage 3 disease, and a 5-year survival of these patients would be somewhere close to about 75 to 80%. But these patients would require chemotherapy as a post-surgery treatment, and I would give this patient a combination of oral as well as IV for a 3 months period. That would be adequate as per the IDEA consortium data.
And with all the advances in colorectal cancer, what's the mean survival period in stage 3 and 4 cases? And is it cost effective to suggest such a treatment at this stage?
It definitely is cost effective to suggest treatment for stage 3 and stage 2 disease, because these treatments are not very expensive. Most of the colorectal cancer chemotherapy for 3 months would not cost for more than 1 lakh rupees combined for the entire 3 months of therapy. The cost for targeted treatments is something which was on the higher side, but now that there are generic drugs which are available, the total cost has come down very well. Still, there are certain drugs which can be made available to patients on a compassionate basis or a named patient basis, or these patients may have access to clinical trials, because there are a lot of clinical trials going on in India and in Mumbai also, where these patients may have access to treatment.
Sir, can targeted therapy and this chemotherapy can be done together?
Yes, it has to be given together, because giving only targeted therapy may not really show a faster response. Most of the targeted therapies work better when combined with chemotherapy, because they do have a synergy, and then at some point of time we can stop the chemotherapy and continue only on targeted therapy, so that the patient's tolerance is also better, the quality of life is better.
So targeted therapy is costly, or
Targeted therapy is costly, but what is the cost of life, that I would ask? I know that these treatments are not for everyone. For those patients who can afford, yes, definitely it has shown that there is a benefit. And we've seen clearly that in a stage 4 patient, if I treat someone with a first line or a second line chemotherapy, I don't have other chemotherapy options third line and beyond, unless I go to targeted treatment. That is the only thing which is going to improve the overall survival. Currently, We have patients who are going on for 3.5, 4 years with a stage 4 disease, and if they are sitting next to you, you would not know that he's a colon cancer patient with metastasis to the lungs or the liver. So the whole concept of understanding these molecular alterations is changing the treatment, and it's just a matter of time before these therapies start becoming cheaper. Just to give you an example, 15 years back when trastuzumab, which is Herceptin, came in for breast cancer, was available for 1,40,000 rupees for a vial of 440 milligrams. Today it is available for 23,000 rupees.
What is
So
the
the cost
impact
will,
of targeted therapy?
the cost will come down. It depends on what each individual is able to afford, and that's where the individualization of treatment comes in. Because each targeted treatment costs different. The immunotherapy cost is roughly about 2.5 lakh rupees for a month. But as I said, it's not for everyone. It is for those patients who are able to have access to it, and for those who would be able to continue for a period of at least 6 months to a year, that we would offer this. It is not for everyone.
What tips for preventing colorectal cancer?
I think the most important thing is to have a good high fiber diet. Try and cut down the red meat consumption and excess salt consumption. Make sure that physical activity and obesity is avoided. And those with a family history of colorectal cancer should definitely be undergoing colorectal cancer screening on a regular basis as per the guidelines, because we do see a lot of patients who do have familial high risk of polyps and adenomas, and these are the patients who should be subjected to colonoscopy screening once in every 10 years and a fecal occult blood monitoring once in every 6 months.
Thank you so much, doctor, for giving wonderful information about the colorectal cancer.
Thank you, madam.
Very much once again. Now
Thank
we
you.
move to the next speaker. The next speaker is Dr. Shubhangi Parker. I request our President-elect Dr. Anil Awad to introduce the speaker. Over to Dr. Anil Awad.
Madam, can you wait for a minute? I wanted to share your
Yes.
questions. Yeah. You'll have to close down your presentation, madam.
Okay. I will.
Yeah, thank you. Yeah. Good afternoon, everyone. From World Kidney Day, now we move on to International Women's Day, and we have a very apt person to speak on this particular day, and none other than Dr. Shubhangi Parker. She has been awarded with many puraskars for her work in the women community as far as mental health is concerned. And today she'll be talking on depression in women. I'll just introduce Madam in short. Dr. Shubhangi Parker is a well-known psychiatrist of the city of Mumbai. She is ex-dean and ex-dean academics at GS Medical College, Mumbai. She is ex-professor and head Department of Psychiatry and ex-chief Drug De-Addiction Center of Excellence at St. GS Medical College and KM Hospital. She has done MD Psychiatry from Mumbai, PhD from Switzerland, and postgraduate diploma in Human Resources. She has received numerous awards throughout her illustrious career. To name a few, Dr. B.C. Marfatia Award and Dr. A.V. Shah Award from Indian Psychiatric Society, Savitribai Phule Puraskar for Mental Health Work in Women, Navshakti Sanman Sohla Puraskar for State, and Punyanagari Puraskar as Empowered Women in Mental Health. She was past president of Bombay Psychiatric Society and Indian Psychiatric Society West Zone and has worked on various subcommittees of IPS. She is ex-member Apex Committee of Prevention of Sexual Harassment at Workplace at BMC. She is also member Mental Health Task Force Maharashtra State. She has published numerous articles in various newspapers as well as books. Her two famous books in Marathi are Vasan Mukta Hoya and Parikshatil Apeshavar Mat Kashi Karar. Over to Madam Parker. She'll be enlightening us on depression in women.
Thank you. Shall I share my screen now?
Yes, yes.
Yes. Okay. It is seen right now, okay?
Yeah, yeah.
Good morning.
And
We
this
are,
slideshow.
okay, yes. Good morning, everybody. I'm going to talk on a major problem globally, that is depression in women. Fortunately, Deepika Padukone, the well-known heroine of Bollywood, has given this particular subject absolute importance, because of which many women are approaching now psychiatrists. These are two anonymous quotes. When you are depressed, you don't control your thoughts control you. I wish people understood that. Second, depression is feeling like you have lost something, but having no clue when or where you last had it. Then one day you realize what you lost is yourself. Globally, it is estimated that 5% of adults suffer from depression. It is twice as common in women. Depression is one of the priority conditions covered by World Health Organization Mental Health Gap Actions Program, and women constitute 2/3 of the patients suffering from common depressive disorder. Treating her depression is a substantial public health concern. 1 in 8 women experience depression in their lifetime, twice the rate as a male.
And your slides are not moving.
Not moving?
Yeah. Make a slideshow, madam.
I had put it on the slideshow only.
Here we cannot see it. It's same.
Oh my God.
Can you just close the presentation and again open?
Hello, what should I do?
Close the presentation and start again.
Okay.
Share it again.
Is this seen now?
Yes, yes. It is seen.
So I would go not for the full show, I'll go for this.
Okay.
That's okay?
Yeah, yeah.
Right. So what is clinical diagnosis? Depression, also called as a major depressive disorder, and ideally it consists of 3 factors. That is the mood disturbances, poverty of ideas, that is the negative ideas, and psychomotor retardation. That simply means the woman becomes slow, or the depressed person becomes slow. The ability to move on decreases. And these are very essential to identify, because people believe that due to stress, there is some reduction in the activity, some slowing down of the thought process. That's not true. One has to probably identify presence of depression. How do you diagnose depression? I think all of us know that there are crying spells, feeling sad, decreased sleep, decreased appetite, loss of weight, decreased energy, a lack of interest, concentration in pleasurable activities, and lot many somatic symptoms. Nevertheless, what is important for us to know, the newer symptoms, that is, atypical symptoms, that is excessive craving for the food, a lot of shopping, irritability. So there are many other newer symptoms which are being identified in women, and that's what we must know, that these are some new symptoms. Women may be more likely to report certain symptoms. So which are these symptoms in depression? Eating or sleeping too much instead of, less sleep, carbohydrate craving, weight gain. Weight gain happens fast, quickly in women with depression in comparison to men. Mood worsening in the evenings, trouble getting to sleep, hostility and irritability. And in fact, that is the reason these mood changes of getting hostile, irritable, violent, Generally, then relatives at home start neglecting her without realizing that this is not the nature. These are the symptoms of depression. The gender difference is very important. Besides the fact that women suffer from depression more often than men, women tend to develop depression at an earlier age. They have depressive episodes that last longer and they recur more often. So these are important perspective when we look at the gender perspective. Women may more often have a seasonal pattern to depression. This is seen more in countries. When I was in Switzerland, I have seen this seasonal pattern more in women, in European women. Regardless of gender, many depression sufferers they can work through. Women, take it personally. They believe that they can work through, they can control their emotions without realizing that this is a depression which has got biological base. So this is where we have to be very careful. Depression is a more disabling condition for sufferers, especially women, than angina, arthritis, asthma, and diabetes. New research from World Health Organization has shown anemia in Indian women is a critical issue. Many women who have depressive symptomatology have very low hemoglobin. So correcting hemoglobin is a very important perspective while treating depression, and associated comorbid illnesses like hypertension, diabetes, cardiac diseases. So these are some of the illnesses can contribute in enhancing or increasing depressive episodes in women. Four depressive conditions specific to women, which I am going to concentrate today. Premenstrual dysphoric disorder, that is PMDD. Depression in pregnancy, a very important issue. Postpartum depression in a mother choosing to breastfeed. Depression related to perimenopause and menopause. So this, I think we need to concentrate even in the general practice. Why are women more at risk for depression? It is genetic, biological, psychological factors and social factors, but we shouldn't forget biological and genetic perspective, because that's something which we cannot control and we really need to pay attention. Genetic factors, some forms of depressions run in families. There is a 25% rate of depression in the first degree relative, mother, father, or siblings of the people with depression, and greater prevalence of the illness in first degree and second degree female relatives. The genetic contribution to risk for the depression is not something specific to women. It is also in men. But interestingly, when you see depression in women, what you see in her sibling who are male is alcoholism. So alcoholism can be a very important representation of depression in men, which we must know. So when we have women who come with the depression, if we want to have the family history, we must inquire history of alcoholism in men in the families. Biological factors, important link between mood changes and reproductive health events in a woman's life. Gender differences in rates of depression emerge when female enter puberty and remain high throughout the childbearing years and into late middle age. We do not see a very strong gender difference in children. Okay, 20 to 40% of menstruating women experience premenstrual mood and behavioral changes, that is PMDD. Approximately 2 to 10% of the women experience premenstrual dysphoric disorder. It's quite a high. 10 to 15% of women experience a clinical depression during pregnancy or after the birth of the baby. In fact, during the pregnancy, it is almost neglected, saying that it's a mood change related to pregnancy. An increase in depression during perimenopausal period is also important. Again, it is attributed to the aging process of the menopausal process without identifying that this can be depression. Differences in thyroid function in between men and women are very important factors to identify. They contribute more in the prevalence of mood disorders in women. A circadian rhythm pattern is very important, which is being studied of late. The complex system that regulates sleep and activity over 24-hour period. Gender differences in the activity of the neurotransmitters, including serotonin, GABA, and sometimes depression matters a lot. And it affects on estrogen on these neurotransmitters are very important factor for us to identify. The PET scans of the brain indicate low activity in a person suffering from depression compared to someone who is not depressed. So it is very much biological, and in women it is more biological because of hormonal changes. Of course, psychosocial factors are very important because they act as a stress, contributing in change in the neurotransmitters. So sexual discrimination, lack of social supports, traumatic life experiences, poverty. It is being said that in African and in developing countries, is if woman is a poor, if she is uneducated, if she is dependent economically, and if she has an alcoholic woman, for sure she will be depressed. And this is also being identified in slum area. My PhD work has been in urban slums. So this is absolutely fact. Individual with low self-esteem, pessimistic views, because they do have depressive cognitions. They have, frustration tolerance, that is what we call as a LFT. It is not liver function test. For us, it is low frustration tolerance that leads to depression. A recent study found that 3 out of 5 of the women diagnosed with depressive illnesses had been victims of abuse. Maybe it is violence or sexual abuse. And 100% of women, very important for us to note, 100% of women who had experienced severe childhood sexual abuse develop depression in later life. And that's the reason why POXO becomes a very important aspect even in health sector. Does pregnancy influence depression? Recent research reveals that over 10% of the pregnant women and approximately 15% of the postpartum women experience depression. Related hormonal and biological changes associated with pregnancy or giving birth are contributory factor. A threefold increase in the risk for depression during or following a pregnancy among women with a history of mood disorder is seen once a woman has experienced a postpartum depression. Remember that her risk of having another reaches by 70%. So it is a very important consideration for us to look at, pregnancy and depression. Postpartum depression is another thing. 1 in 8 women experience symptoms of postpartum depression. Feeling numb or disconnected from baby, worrying that you will hurt the baby, feeling guilty about not being a good mom, or doubting your ability to care for the baby. These are some of the important aspects. In KM, in between, there was a patient called Deepika Parmar. She killed her infant, and this case is still going on. I'm fighting this case on postpartum depression, and it's quite a trouble. What are the factors which leads to postpartum depression? Many factors like difficulty getting pregnant before, being a mom to multiples like twins or triplets, being a teen mom, a young woman can develop postpartum depression. Preterm, before 37 weeks, labor and delivery can develop depression. Pregnancy and birth complications also can lead to the postpartum depression. Having a baby who has been hospitalized, a very sick baby, can lead to postpartum depression. So some of these issues obstetricians have to be, keeping into mind. And if it is a woman is irritable, we actually have to rule out postpartum depression. Depression and menopause. Women appear to be particularly vulnerable to depression during perimenopause and years immediately after menopause. And there is double the rates of depression during this period. One theory is the window of vulnerability. That is because a lot of hormonal changes, a past history of depression, a loss of spouse, or many other economical factor. So that window of vulnerability we have to keep noting around. In depression, professional treatment is helpful for all these types of depression. I mean, one cannot manage on their own. Okay. A first episode of depression may require 6 to 12 months of medication to prevent recurrence of symptoms. So not before, sometimes people try to stop the depression when start feeling good within 3 months. I think feeling good comes early. Feeling, getting good comes little later. So we have to wait till women get good. Okay, so 6 to 12 months to prevent recurrence of symptoms. But permanent medication for a first episode is required only in rare circumstances where there is a strong genetic loading. Okay, once it becomes exposed, the depression becomes exposed in a strong genetic loading, I think to maintain the quality of life, perhaps one has to continue the maintenance doses of antidepressant. Chronic depression need longer treatment, and with comorbid conditions, longer treatment is essential. Now, these comorbid conditions majorly are medical conditions like most of the lifestyle diseases. These are very important factors, malnutrition, anemia. So these are the condition needs to be treated proactively and aggressively. Treatment options are many. Antidepressants, electroconvulsive therapy is extremely good treatment in postpartum depression and depression with suicide. Transcranial magnetic stimulation, psychotherapies if the psychiatrist is trained. I do practice because I'm trained in cognitive behavior therapy and rational emotive behavior therapy, which works best in the treatment of depression, and approach should be tailor-made. It's not a very general approach. We really need to understand the comorbid illnesses, personality, the type of depression, and accordingly, we have to start managing the depression. See, major depression in psychiatry is almost equivalent to hypertension in general medicine. Okay, so clinicians have a wide array of mechanistically different medications to select from, and more than 50 different antidepressants belonging to pharmacologically distinct classes are available even in Mumbai today. Now, this is the range of most of the antidepressant. So we know we can change looking at the 6 to 8 weeks of the antidepressant effect on a woman. So menu of reasonable choices we have, options and negotiations can be done. Patients should be trained. So these are a very important, and these are important in terms of the indications, in terms of the contraindications, and these are a good days for us as a psychiatrist because we can choose, we can negotiate, we can have options for a patient. Treatment of depression, antidepressant remains a mainstay treatment. Okay, selective serotonin reuptake inhibitors, like right from the citalopram, escitalopram, fluoxetine, paroxetine, fluoxamine, sertraline, these are, the first line drugs. Tricyclic antidepressant, amitriptyline, imipramine, they are very effective, extremely effective. Efficacy as good as SSRI. In fact, SSRI are as good as these drugs. However, side effect profile makes us to go for SSRI. But if the patient doesn't respond to SSRI, we have to go to tricyclic, which are very, very effective. Electroconvulsive therapy, which is useful in severe depression, because antidepressant take time, 6 to 8 weeks, while electroconvulsive therapy, act faster, so we can prevent suicide attempts. Okay, it helps to balance the levels of neurotransmitters in the brain faster and equally. Hospitalization in severe depression and with suicide is must. Good news about antidepressant, I mean, there should be Madhuri Dixit's smile on the face, that up to 2/3 of the patients respond to any given antidepressants if we are selecting it scientifically and with a tailor-made approach. Half of depressed patients recover within 6 months and about 3/4 within 2 years. When they don't respond, there is some garbad. That is, the dose is not adequate or the antidepressant is not suitable for the client. So we have to probably start analyzing the suitable antidepressant and the optimal dose. Lower doses of antidepressant, they are of no use. Antidepressant reduce relapse rates. This is very important. Up to 90% patients respond to one or combination if multiple therapies are tried. Now, what are these multiple therapies? To begin with, antidepressant and absolute scientific psychotherapies. Counseling means just not talking. Advice giving is not therapy. Therapy for depression is very specific and it deals with the thought processes, and identifying those thought processes is skill. So telling patient, oh, you will be all right is good supportive therapy, but it's not the specific therapy for depression. Treatment, psychosocial support is very essential. Counseling and encouragement generally should be done. Cognitive therapy. What cognitive therapy means is identifying the deformed thought process and rectifying that, and it requires skills. So there are techniques to do that, and it helps people to change negative thinking, behavior patterns, and attitudes that affect self-esteem and overall sense of well-being. What we do is we change LFT. LFT is low frustration tolerance. Surprisingly, some people, even highly educated people, they do have low frustration tolerance. So they tend to give up fast. If we work on low frustration tolerance, that is LFT, most of the people become empowered, in terms of the thinking process. And for a woman, empowering her thinking process in terms of the thinking, cognitive therapy or rational emotive behavior training by Albert Ellis, and both of these are wonderful men who taught most of this therapy to most of us. Many women have learned from them. Okay, so these are very important perspective we must know. Important issues. Antidepressant as first line along with psychotherapy treatment in pregnant women if it is severe and risk of relapse. Okay, we hesitate. How can we give a treatment in pregnant woman? Remember that depression is worst thing to happen to a woman. Okay, and to a child, to an infant. And that's the reason why we have no choice but to treat women. Okay, so this is where we have to give antidepressant, and if it is severe, if it is neglecting women's health, if she's going for the malnourishment, if it is affecting child's infant's health, I think we have no choice but give antidepressant in all the trimesters, because there is no evidence as it that antidepressant cause this damage or that damage in pregnancy or in child. So in absence of strong evidence and in presence of huge high risk in the women, antidepressant play very important role even in pregnant women. Women who try to conceive and develop major depressive disorder, if it is severe depression, continue medications and psychotherapy. Okay, many women, in depression, they are going through the treatment for infertility and they don't respond well, and their depression is continued. In fact, we do everything about infertility. We do not take care of depression, and that's the worst thing to happen to a woman. So if it is a mild, still it should be touched with the expert psychiatrists or expert psychotherapists, to motivate her. Or if it is, moderate to severe, don't think twice. Go ahead and give antidepressant. For severe major depressive disorder in any trimester, you have to continue antidepressant because benefit is much more than any trouble or any problem. Important issues in postpartum depression, rapid attention and aggressive treatment of this depression is imperative. Okay. Prophylactic treatment doesn't work. There is no evidence for that, because many physicians asked me that she had a postpartum depression in last pregnancy. Can we give prophylactic? There is a little bit less severe depression, but it's not, it's given. I mean, there is no agreeable consensus guidelines about this all over the world. So we have to see, if there is depression, we should be ready to give assertively. The choice here is SSRI. And if the depression is severe, suicidal, the risk of infanticide, then consider ECT. The mother becomes quickly all right within 2 weeks' time, and then continue antidepressant. The dose of antidepressant also remains less. So this is a very important issue in the postpartum depression. We must take care of that. Perimenopause, a very, very important aspect. There is a longevity in the women. It is being appreciated all over the world. Women live longer. But trouble is that women have depression a lot. So when they live longer and they have to live with depression, that's not a fair deal. Okay. And this is where the depression has to be treated, again, assertively, proactively, if it is moderate to severe. Okay, if the sleep hygiene is a very important aspect. If you look at the sleep is suffering, woman is getting up at 4 o'clock, 2-3 hours before her normal sleep. This is where we have to start looking at whether there is a depression. Okay, generally people believe, post-retirement, what kind of concentration you will have, what kind of interest you will have in the life. No, I mean, don't forget that most of the politicians who are ruling us in the world and in our country too are, if we can consider women, they are in almost perimenopausal state. Okay, so they are 50, 65, 70. So they are doing the things with interest, with total concentration. So for a woman, it should not be, negated that her productivity is going to be less. Not necessary. So perimenopausal depression has to be treated aggressively, proactively, passionately. Okay, if it is a mild depression, psychotherapy can be given, but psychotherapy is not the answer for months and months. Okay, you can give it in the first month and see what happens. Otherwise, first line treatment is antidepressant in severe depression along with therapy, possibly in combination with HRT as second line. Okay, HRT should not be first line, it should be second line, and augmentation with many other drugs like thyroid, like lithium. But we have to get women out of perimenopausal depression, because she needs to enjoy. We are talking about International Women's Day. So it's a human right. I do look after, I'm a human right oriented person. I mean, one of the degrees that, and feeling happy is a human right. And for a woman, feeling happy, feeling constructive, enjoying life, is a woman right. Okay. So woman must probably enjoy the life even during the perimenopause. So augmentation with many, many drugs we can do. And there is a possibility. So don't forget, depression in women has to be treated. It's not the habit of the woman. It's not the style of the woman. It's not just the nature of the woman. Depression can never be nature of anybody, neither men nor women. Okay, so it has to be treated, and that's where we have to be active. We have to be proactive rather, and this is where we have to understand that woman, even after depression, can be a topmost lady. She can be a topmost person in Bollywood. She becomes absolutely famous in the world. And this is where we must remember that depression in women is treatable and has to be treated. There should not be hesitancy from us as a doctor. Thank you very much.
Thank you, doctor. Now there is one question. What antidepressants are suitable in all the trimesters of pregnancy? And also what are the suitable antidepressants during lactation?
Yes. in all the trimester of the pregnancy, during the pregnancy, the SSRI, that is fluoxetine, is because it has got a good effect. Okay, it is effective and there is no drug reaction. See, SSRI are safe that way. Okay, the alternates are sertraline. In previous era of SSRI, we have used tricyclic, as a student. I mean, SSRI came after I passed my MD, but we have used tricyclic antidepressant. Paroxetine is there. Okay, in the breastfeeding, remember, combine SSRI with concrete supportive services. So support is required. See, in pandemic, most of the women who delivered babies had no support. So they suffered a lot. There was a huge depression. Almost every day I used to get a call on telepsychiatry. I used to counsel and then give safe medication. In breastfeeding, sertraline is a very safer medication. Alternative is paroxetine. Okay, fluoxetine also can be given, but little bit trouble with fluoxetine as a SSRI. There is a paradoxical agitation. So no, you start missing that aspect. What this agitation is about? Is it a part of the depression or is it a part of the side effect of the SSRI? So we have to look into that. So start low, go slow. That is the strategy, which is a very important. We must have the patience while we treat hypertension. Most of the physicians, they do have patience. We must have the same patience while treating depression in the pregnant lady, in the lactating lady, and also the lady who undergoes infertility. I think that point is missed in most of the setup. Infertility is treated without treating associated depression. If you see this, maybe there will be the many more success stories we will be able to see. Yes.
Thank you so much, madam.
Yes, thank you.
Yeah.
Thank you, madam. And now we move on to the next topic, and this is related to World TB Day. And we have a small video from our chairperson of the World TB Day, Dr. Suresh Doshi.
Good morning, President Dr. Jitesh Mehta, Honorary Secretary Dr. Girish Lal, today's speaker Dr. K.T. Utpat, and Dr. Rajendra Narvane, and all delegate friends. Today, we are celebrating World Tuberculosis Day for creating public awareness about global epidemic of TB and effort to eliminate TB from the world. Theme of the TB awareness for the 2022 is Invest to End TB, Save Lives. It is a Herculean task to diagnose and to treat 40 million people, TB patients, in 2022. Friends, before I hand over mic to Dr. K.T. Utpat, I request Dr. Anil Awad to play video of TB control, which video is prepared by IMA Mumbai branch with the stalwarts of IMA Mumbai branch as actor and artist. Over to Dr. Anil Awad.
आओ लोगों तुम्हें बताए टीबी की ये नई कहानी। अब आई नई योजना, टिक ना पाएगी बीमारी। आओ लोगों तुम्हें बताए टीबी की ये नई कहानी। अब आई नई योजना, टिक ना पाएगी बीमारी। टीबी कंट्रोल, टीबी कंट्रोल, टीबी कंट्रोल, टीबी कंट्रोल। आइए मैंने ठान लिया है टीबी को भगाएंगे। भारत के घर घर से हम टीबी को हटाएंगे। यहाँ मिलेगी हर दवाई बिना किसी चार्ज के। जांच कराए आप सभी खांसी और बलगम की। अब आई नई योजना टिक ना पाएगी बीमारी। टीबी कंट्रोल, टीबी कंट्रोल, टीबी कंट्रोल, टीबी कंट्रोल। हम सब ने मिलकर देखो टीबी को ललकारा है। गांव-गांव और गली-गली से टीबी भाग रहा है। घर-घर में दिवाली और खुशियों की लहरें हैं। इसे देखकर घर-घर से बच्चा-बच्चा बोला है, अब आई नई योजना टिक ना पाएगी बीमारी। टीबी कंट्रोल, टीबी कंट्रोल, टीबी कंट्रोल, टीबी कंट्रोल। आओ लोगों तुम्हें बताए टीबी की ये नई कहानी। अब आई नई योजना टिक ना पाएगी बीमारी। टीबी कंट्रोल, टीबी कंट्रोल, टीबी कंट्रोल, टीबी कंट्रोल।
Thank you very much, Piyush, for playing the song for us. It was shot in IMA Mumbai branch office with all stalwarts from IMA Mumbai branch office bearers. Now I request Dr. Usha Shah, Assistant Director of IMA CGP, to introduce Dr. Ketki.
Thank you, Dr. Anil Awad. Dr. Ketki Utpat is Associate Professor, Department of Pulmonary Medicine at TN Medical College and BYL Nair Charitable Hospital. She has done MBBS, MD, Pulmonary Medicine, DNB Respiratory Medicine, European Diplomate of Respiratory Medicine, Hermes. She had won the Young Scientist Award for paper presentations on profile of drug-resistant TBE at NAPCON conferences 2018. She has a 64 national and international paper presentations to her credit. She had delivered many interviews on DD Sahyadri Arogya Sampada on COVID and other respiratory topics. Today she will be speaking on TB today and tomorrow. Over to Dr. Ketki Utpat. Welcome, madam.
Thank you so much, madam. Good morning, respected seniors, dear colleagues. I am Dr. Ketki Utpat, Associate Professor, Department of Pulmonary Medicine from TNMC and BYL Nair Hospital. It gives me great pleasure today to interact with such esteemed audience on this bright March Sunday, which is preceded by International Women's Day and will be succeeded by the World Tuberculosis Day. As Sir has said, the theme of World Tuberculosis Day 2022 is Invest to end TB and to save lives. So with this introduction, I enthusiastically open my topic, tuberculosis today and tomorrow. So we are steadily and proudly marching towards tuberculosis elimination. And at this juncture, it will be worthwhile to use this opportunity to strengthen our basics about tuberculosis, to consolidate the basics, and then to build on the recent advances. Now, tuberculosis is a disease which needs no introduction. And I won't go into the statistics today, but will only say that it is a ubiquitous disease, and except for the nail and the hair, there is not a single organ in the body which has been exempted from tuberculosis. And hence, each and every doctor, be it a physician, a surgeon, a gynecologist, pediatrician, or an anesthesiologist, we all have to deal with tuberculosis at some point of time. The traditional classification of tuberculosis has always been dividing it into pulmonary tuberculosis or extrapulmonary tuberculosis, depending on the presence or the absence of pulmonary parenchymal involvement. when there is involvement of lung parenchyma with or without the involvement of other organs, it is termed as pulmonary TB, and extrapulmonary tuberculosis is involvement of any other organ other than the lung parenchyma. A point worthwhile to remember is many times pleural effusion is misclassified as pulmonary tuberculosis, but I would like to clarify that tuberculosis is an extrapulmonary form of tuberculosis. Also, another classification for tuberculosis, depending on the sensitivity of the organism to the first-line anti-TB drugs, is as drug-sensitive tuberculosis and drug-resistant tuberculosis. Drug-resistant tuberculosis can further be subclassified into multi-drug resistant tuberculosis or extremely drug-resistant tuberculosis. Also, let us just quickly revise few important definitions. Now, what do we mean by presumptive tuberculosis? So, presumptive tuberculosis is a term that has replaced the erstwhile term of tuberculosis suspect. So, any patient which has a subacute onset of illness, symptoms of a minimum 2 weeks duration in the form of respiratory symptoms like cough, fever, chest pain, or breathlessness, or non-respiratory symptoms pertaining to the organ involvement, becomes a tuberculosis suspect. A tuberculosis suspect is further worked up and is confirmed to be a tuberculosis case. Now, this case can be either a microbiologically proven case or a clinically diagnosed case. By recurrent tuberculosis, we mean a person who has been previously treated for tuberculosis and has now again come back with a sputum positive status. By cured, we mean a person who has successfully completed anti-tuberculosis treatment and has been microbiologically converted to negative. So, what all diagnostic tests do we have in our basket for confirming diagnosis of tuberculosis? So, the diagnosis of tuberculosis should always be an amalgamation of clinical symptoms, which is supported by relevant radiology, also ancillary tests like tuberculin skin test or an adenosine deaminase level, and most importantly, microbiological confirmation with rapid diagnostic tests. So, what are the microbiological tools available for confirmation of tuberculosis? In each and every form of tuberculosis, be it pulmonary or extrapulmonary, all attempts should always be undertaken for confirming the microbiological diagnosis. Especially in this era of precision medicine, microbiological diagnosis is of utmost importance. So, in the microbiological diagnostic tools, we have sputum smear microscopy by Ziel-Nielsen method of fluorescence staining. We have the culture methods in the form of solid and liquid culture media, and we have the rapid molecular diagnostics in the form of line probe assay and the CB-NAT. So, coming to the first modality, that is sputum acid-fast bacilli smear. So, this is the simplest, cheapest, and the most basic point of care confirmatory test. However, there are certain fallacies of this test. First of all, it requires a higher microbiological load to get a sputum AFB smear positive, and sometimes there might be problems in acquiring a specimen, particularly in the extremes of ages, like very young children or in elderly population. Also, it has a relatively poor sensitivity, particularly in paucibacillary, that is extrapulmonary tuberculosis. And lastly, it does give us a confirmatory result about tuberculosis, but it does not help us to differentiate between from drug sensitive and drug resistant tuberculosis. So now, moving ahead to the next diagnostic modality, that is a culture media. So previously, traditionally, LJ culture medium has been in use. However, in the current era, it is now replaced by faster culture media, which has a rapid turnaround time in the form of liquid culture media, that is MIGIT or microbacterial growth indicator tube. Coming to the next modality of investigation, that is line probe assay. Now, this is a molecular test which helps us to detect mycobacterial tuberculosis and also to identify resistance to rifampicin and isoniazid at the same time. And it has reduced the time to tuberculosis diagnosis to 3 days. and it is specific for Mycobacterial tuberculosis complex. Thus, we can help differentiate between Mycobacterium tuberculosis from other non-tuberculous mycobacteria. However, there are certain limitations in the form of it is not of use for monitoring patients on treatment because it can even detect dead bacilli. It is dependent on smear results and can only be performed on smear positive or culture positive samples. And yes, it is labor intensive and also prone to contamination. And coming to the last rapid modality, that is the gene expert, also popularly called as CB-NAT, that is cartridge-based nucleic acid amplification test. This is the most rapid molecular test currently available for diagnosis of tuberculosis. It detects Mycobacterium tuberculosis and also detects rifampicin resistance at the same time. And the processing time, turnaround time is as less as 2 hours. Also, it is specific for the MTB complex. And yes, I wish to clarify that this can be used not only over sputum, but it can also be used on various body fluids such as cerebrospinal fluid, pleural fluid, pus aspirate from the lymph node, and it can also be used on tissue samples. For example, pleural biopsy or an abdominal biopsy. It is carried out in a closed system, cartridge-based, and hence there is a minimal or less risk of cross-contamination and human error. In Gene Expert, in the current era, further modifications are available in the form of TrueNAT or Ultra Gene Expert. These are the updated versions of Gene Expert, which are even more sensitive and even more rapid. Now coming to the individual forms of tuberculosis. So first form of tuberculosis, which is very, very relevant and important, is pulmonary tuberculosis. And why is it the most relevant and important form of tuberculosis? Because firstly, it is multibacillary, and secondly, it is the only form of tuberculosis which is infectious. So when do we suspect pulmonary tuberculosis? We suspect pulmonary tuberculosis when any patient comes to us with symptoms of more than 2 weeks duration in the form of respiratory symptoms like cough, breathlessness, fever, and hemoptysis. So once we suspect, how do we proceed to confirm our diagnosis? So confirmation of tuberculosis, pulmonary tuberculosis, is always based on microbiological diagnosis. The best sample for microbiology is a deeply coughed out sputum sample. And here I would like to share our experience, that is, if a proper sputum sample is given, then the yield of sputum smear positivity or Gene Expert in diagnosis of pulmonary tuberculosis is almost in the ranges of more than 95 to 99%. Yes, and that is true. However, there are certain very basic points which we should always remember when a patient submits a sputum sample. Ideally, it has to be a supervised sample, because if a salivary sample is given, then the yield of AFB smear positivity and even Gene Expert goes drastically down. So patient has to submit minimal 5 ml of sputum. That has to be a deeply coughed out sample. It has to be mucoid sample, and ideal would be an induced sputum sample, where before sputum production, the patient is given a simple saline or a hypertonic saline nebulization. However, rarely patients can come to you with difficulties in producing sputum. So what are the alternatives? Here, if it is a pediatric patient, we can go ahead with a gastric lavage. If it is an adult patient, even after a sincere attempt of sputum induction, if the patient is not able to produce sputum, we can go ahead with something known as a tracheal aspirate or bronchoscopy to take bronchial washings. Hence, always and always, microbiological diagnosis has to be emphasized. In pulmonary TB, there could be some intricacies in diagnosis because there is a great deal of clinical overlap with other non-tuberculous respiratory diseases in the form of pneumonias or sometimes even lung malignancies. And sometimes radiology in tuberculosis can also be varied and misleading. As we can see, these are the various chest radiological patterns which are seen in pulmonary tuberculosis. We can see these are in the form of a dense opacity in the form of collapse, or there is an opacity with air bronchogram in the form of consolidation. Sometimes there could be bilateral patchy alveolar opacities. And lastly, we can have tiny nodular, micronodular opacities in cases like miliary tuberculosis. And in some cases of miliary tuberculosis, the chest X-ray can even be normal. Hence, radiology should never be used as a modality to exclude or confirm tuberculosis. Always and always, the suspicion is on clinical grounds and confirmation should be microbiological. This is the diagnostic algorithm for pulmonary tuberculosis that is given under the program. I would like to simplify it further for clinicians. Whenever we come across a presumptive tuberculosis case, how do we move ahead? We first and foremost do a chest X-ray. If the chest X-ray shows active opacities, then we go ahead with a sputum smear and a gene expert, that is a CBNAT at the same time. If sputum smear is positive or gene expert detects Mycobacterium tuberculosis, then the patient becomes a microbiologically confirmed case of tuberculosis and we go ahead with the treatment as per the protocols. However, if the chest X-ray is clear, we can ask the patient to come back with a sputum smear sample and then we can give the patient a course of antibiotics. If the patient again comes back with symptoms, then it is worthwhile undergoing a repeat chest X-ray and submitting the sputum sample for gene expert and CBNAT. If there is chest X-ray is normal and if the patient has clinical response to antibiotics, we can wait and watch for the patient. Now coming to extrapulmonary tuberculosis. This could be of various forms, but there are certain basic features that remain common to all forms of extrapulmonary tuberculosis. These are all paucibacillary tuberculosis, and therefore they pose certain problems to the treating physician. Because they are paucibacillary, obtaining a sample in this case sometimes becomes difficult. And also, after obtaining a sample, the yield of smear and gene expert is very less, and often smear and gene expert could be negative. Still, an earnest attempt should always be made to get a sample for microbiology in the form of either a biopsy sample or a body fluid sample. In cases of extrapulmonary tuberculosis, supportive investigations play a very vital role in the form of either a tuberculin skin test or adenosine deaminase, for example, in cases of pleural effusion or ascites. And hence, the diagnosis is always by clinical, radiological, histological, and microbiological synergy. But we should always remember that treatment should never be given for more than 6 months, as if 6 months of treatment is sufficient for multibacillary tuberculosis like pulmonary TB, then of course logically it should be sufficient for all forms of extrapulmonary tuberculosis as they are paucibacillary. Now just rushing through the various forms of extrapulmonary tuberculosis and what should be our approach. Suppose we come across a patient with lymph node swelling. So how to go ahead? Patient will give a subacute history of fever and a progressive increase in size of the lymph node. Initially, to begin with, we can give a tuberculin skin test so that it will serve as an ancillary evidence of tuberculosis. Then depending on the swelling, if it is fluctuant, we can go ahead with a fine needle aspiration of the swelling and the pus can be sent for a gene expert and FB smear and culture. And if it is a firm swelling, then we can go ahead with a true cut biopsy, also called as fine needle aspiration biopsy for the swelling. Again, this biopsy sample has to be submitted for gene expert and AFB culture. Now, the commonest fallacy or commonest loophole which we come across when patients with lymph node follow-up to us is, they come to us with just a histopathological report. Many times they visit some clinician, the clinician gives some course of antibiotics, or sometimes they are started on empirical antituberculous therapy. Fine needle aspiration cytology or fine needle aspiration biopsy is attempted, but sample is just sent for histopathology and the patients come to us with a granuloma. Now, as we all know, just like radiology can have a basket of diagnosis, similarly, granuloma also can have multiple differential diagnoses in the form of sarcoidosis or any other granulomatous disorders, and any extremely rare conditions, even malignancies can present with granuloma. Hence, always and always, whenever the patient undergoes an invasive investigation in the form of any biopsy, do remember and always send a sample for gene expert as well as AFB midget culture. Next, we come to pleural effusion. So pleural effusion patients generally present to us with a subacute onset of symptoms in the form of cough, pleuritic chest pain, and breathlessness. So when we are encountered with a case with pleural effusion, How do we proceed? We go ahead with a pleural fluid aspiration. Pleural fluid aspiration can either be a serous fluid or it can be pus. If it is pus, then it has to be treated, and also any pus in the body anywhere has to be drained. So we have to go ahead with either a therapeutic aspiration of the pus or we can put in an intercostal drain. The yield of pus for gene expert is very, very high. However, if it is a serous fluid and it is exudative and lymphocyte predominant on routine microscopy, and we do not have a gene expert positivity, then it is worthwhile considering the patient for pleural biopsy. Now, pleural biopsy can either be a closed needle pleural biopsy, or it can be a image guided pleural biopsy, or a thoracoscopy guided or a fluoroscopy guided pleural biopsy. However, again, I wish to underline that always make an attempt to send either the pleural fluid sample or the pleural biopsy sample for microbiology in the form of gene expert and AFB culture. Coming to spinal TB, here the patient can present with backache, difficulty walking, and fever. Radiology plays a very, very important role in this situation. Either a CT or MRI spine, whichever is done, may show a vertebral lesion, it can show a paraspinal abscess, or it can show a psoas abscess. So accordingly, we can proceed with either aspiration of the paraspinal or psoas abscess for gene expert and AFB smear and culture, or we can go ahead with the biopsy of the vertebral lesion that can subsequently be subjected to histopathology and an AFB smear and culture. Next, coming to abdominal tuberculosis, patients can present with varying symptoms in the form of irregular bowel habits, fever, hematemesis, pain in abdomen, or sometimes melena. Most commonly, the involved site is the ileum with the involvement of the ileocecal valve. Abdominal lymph nodes are also involved, and omental thickening or mesenteric thickening can be seen. Subsequently, various samples which we can send for microbiological analysis can be either the ascitic fluid or a colonoscopic biopsy samples, again to be submitted for histopathology and microbiology, both simultaneously. Coming to the last form of extrapulmonary tuberculosis, which is very, very important, is a CNS tuberculosis. CNS tuberculosis can be classified into three clinico-pathological categories, that is tuberculous meningitis, tuberculoma, and tuberculous arachnoiditis. Clinical presentation again can be varied. Patient can present with fever or any signs of any focal neurological deficit, or patient can present with seizures and headache. Diagnosis essentially rests on a due clinical suspicion and a lumbar puncture with examination of cerebrospinal fluid. Now, the sensitivity of AFB smear and culture for CSF is 58 to 70%, and the sensitivity of WHO accredited rapid diagnostic in the form of CBNAT is to the range of 70 to 75%. Radiology also becomes extremely relevant here in the form of MRI showing leptomeningeal enhancement, tuberculoma, or basal exudates. So, be it pulmonary or extrapulmonary TB, always emphasize on a microbiological diagnosis. So once we have the diagnosis in our hand, let us go ahead to the treatment of drug-sensitive tuberculosis. As I had said, treatment always has to be after microbiological confirmation, but yes, as every rule has an exception, this too has an exception in the form of few situations in which you should consider empirical anti-tuberculous therapy to your patient even before microbiology is available. And these are certain forms of tuberculosis like miliary tuberculosis. This is a form of tuberculosis which has hematogenous dissemination, and if not treated in time, it has a very, very high mortality rate. Hence, whenever we are suspecting miliary tuberculosis, after obtaining a sputum for microbiology, it is worthwhile to start the patient on empirical anti-tuberculous therapy while your reports are awaited. And the next situation is a patient with life-threatening hemoptysis. Again, this is a situation in which time becomes very, very relevant. So, anti-tuberculous therapy started in time can save precious life. Hence, this is the second situation in which you should consider empirical anti-tuberculous therapy before your microbiology sample is obtained or if the report is obtained. In each and every other situation, always request for microbiological confirmation. So now, how to treat drug-sensitive tuberculosis? As in every disease, counseling for treatment of tuberculosis is of paramount importance, and many times this is undermined. However, well-counseled is half the battle won against tuberculosis, be it pulmonary or extrapulmonary. Hence, counseling your patient that first and foremost, it is a curable disease. If it is pulmonary tuberculosis, it is infectious. Then coming to the nature of the therapy that the patient has to take, yes, there could be a range of side effects of varying intensities which the patient has to be aware of. And in the occurrence of such side effect, patient has to consult his physician immediately. And always discourage self-modification or self-interruption of therapy. So now how do you go ahead with the treatment of TB? So correct drugs given in the correct combination, in the correct dosages and correct supervision forms the tetrad of a successful tuberculosis management. And now in the current guidelines, we have shifted from revised National Tuberculosis Control Program to National Tuberculosis Elimination Program. And there has been a paradigm change in the principles. We have moved on from an alternate day regimen to a daily regimen. We have now shifted from the previous multi-blister packets to something which is known as fixed dose combinations. Now, what are the advantages of FDCs? First and foremost, pill burden is reduced. The patient compliance is obviously better. The bioavailability of the drugs is better. And also, the phenomenon of selectively discontinuing a particular drug from the regimen and selective development of drug-resistant mutants is abated. Because in the multi-blister pack, if the patient observes that he is not able to tolerate a particular anti-TB drug, the patient selectively sometimes keeps away that particular TB drug and takes the other drugs. So this propagates multi-drug resistant tuberculosis. But in FDC, this phenomenon is totally avoided. Next, there is a strong emphasis on weight adjustment, which is very, very important to decrease the overdosing related adverse drug reactions. Next is there has been an addition of ethambutol in the continuation phase. And now, previously, as we know, there were category 1, category 2, category 3. Then category 3 was deleted and we just had cat 1 and cat 2. And now there are no more categories in the revised guidelines. We just have a single regime for treatment, even for a new case or a retreatment case. And the regimen is of 6 months duration in the form of 2 months of isoniazid, rifampicin, pyrazinamide, and ethambutol, followed by 4 months of isoniazid, rifampicin, and ethambutol. So this takes care of all interactions. This takes care of prevention of multi-drug resistant tuberculosis, and this also takes care of a baseline level of isoniazid resistance which is available in the population. So now once we start your patient on therapy, how do we follow up the patient? We follow up the patient clinically as well as laboratory. We follow up the patient at monthly intervals. We check for symptoms, there is defervescence of symptoms or no. Are there any development of new symptoms? Whether the patient has any therapy-related adverse drug reactions, whether the therapy is weight adjusted, and whether the comorbidities are taken care of. And at the same time, we reassess the patient with radiology, and also we go ahead with a repeat sputum smear microscopy or a culture. So, despite of a proper treatment of tuberculosis, sometimes we have the development of drug resistance. So now what are the various factors which contribute to the development of drug resistance? As it is rightly said, drug resistance is largely a man-made phenomenon. To a certain extent, it is microbiological in the form of whatever be the TB treatment, there are certain drug-resistant mutants. And if selective growth of drug-resistant mutant happens, then the patient can have drug resistance. However, largely it is a man-made phenomenon, and the causes can be divided into either physician-related factors, program-related factors, or patient-related factors. There could be various factors such as inappropriate guidelines, non-compliance, or poor training of the healthcare workers, or financial constraints. Or there could be poor quality of medicines, non-availability of certain medicines, or wrong dose or wrong combination prescribed for the medicines. Or on the part of the patients, sometimes there are errors in the form of interruption of treatment, irregular treatment, and this can have various reasons in the form of lack of awareness or adverse effects to therapy, or hindrances in treatment because of other factors like social barriers, HIV, diabetes mellitus, or undernutrition. However, still MDR is an essentially treatable phenomenon. So once we have a presumptive DRTB suspect, when do we suspect that a patient could have DRTB? First and foremost, there is worsening of the patient's symptoms. There could be new onset symptoms. There could be worsening radiology, and there could be associated history, like the patient gives history of interruption of TB treatment or irregular TB treatment. There could be predisposing factors like patients who are DRTB contacts, previously treated patients, and HIV and TB co-infection. So all these are the factors which we should consider while terming a patient as a presumptive DRTB suspect. And when we suspect, always we should microbiologically confirm it with WHO accredited rapid diagnostics. So now, once DRTB is confirmed, how do we move ahead to treat it? The treatment of DRTB has undergone a drastic change with the new WHO 2018 guidelines coming in which DRTB drugs classification has been largely simplified, and it has been just put into 3 groups, that is Group A, Group B, and Group C, as against the previous complicated classification. So how do we remember it? Group A includes 3 drugs. It can be remembered as LLB, that is levoflox, linezolid, and bedaquiline. So Group A has LLB, Group B has in the form of double C in the form of clofazimine and cyclosidine, and rest all the other drugs, be it first-line drugs like ethambutol, high-dose isoniazid, or streptomycin, or newer drugs like dilamenide, imipenem, cilastin, meropenem, everything comes in Group C. So again, I repeat, Group A involves LLB, levoflox, linezolid, bedaquiline. Group B involves double C in the form of clofazimine and cyclosidine, and Group C involves rest each and every other drug. So now, once we know about this classification of DRTB drugs, how do we manage a patient of DRTB? The basic principles of TB management remain the same, be it drug-sensitive tuberculosis or be it drug-resistant TB. Always a thorough pre-treatment evaluation has to be done because adverse drug reactions are common in drug-sensitive TB and they are more commoner in drug-resistant tuberculosis. Hence, a meticulous pre-treatment evaluation has to be done. Counseling, as it is relevant in drug-sensitive TB, it is even more relevant in drug-resistant TB because the regimens are longer, it is complex, and also the range of adverse drug reactions is wide. And the patient has to be referred through a proper channel to initiate treatment. The factors which we consider while designing a regimen is, we should give a minimum of 4 drugs to which the patient has never been previously exposed. The selection of the drugs is ideally from category 1, category A, or Group A and Group B. So, if possible, all the 3 drugs from Group A and all the 2 drugs from Group B have to be used. The patient has previously been exposed to any drug out of these, or the patient has a documented drug sensitivity test results which shows resistance to these, then the drugs from the other drugs from category C can be used. So, updated regimens for treatment of drug-resistant tuberculosis are as patients with MDR tuberculosis who do not have history of any prior exposure or they have been exposed for less than a month, they do not have resistance to fluoroquinolones, they do not have extensive pulmonary parenchymal damage, they are more than 5 years of age and they are non-pregnant, all of them can be considered for a shorter duration of therapy as per the new guidelines. So in this, intensive phase is given for 4 to 6 months, which involves bedaquiline, levofloxacin, then you give clofazimine, and then drugs from category C in the form of high-dose isoniazid, ethionamide, parazinamide, and ethambutol. In the continuation phase, you knock off the bedaquiline and you knock off the ethionamide, INH, and INH, and you give just 4 drugs in the form of levoflox, clofazimine, parazinamide, and ethambutol. The longer MDR-TB regimen is given in patients who have any exclusion criteria to bedaquiline containing regimen. They are XDR tuberculosis or they have been exposed to the anti-TB drugs for anti-TB second line drugs for more than 1 month. So the conventional regimen, again, this is all oral. Injectables have now been removed away from the program. So all oral longer regimen consists of 18 to 20 months. And as we can see, all the 3 drugs from Group A in the form of LLB, levoflox, linezolid, bedaquiline, and all the 2 drugs from group B, that is clofazimine and cyclosimine are used. And in the continuation phase, bedaquiline is knocked off and the other drugs are continued. So this is the current simplified version for treatment of drug-resistant tuberculosis. Indeed, drug-resistant tuberculosis is also a very, very curable disease. So now I would just like to conclude my lecture with few take-home pearls. So suspect in time, confirm in time by microbiological confirmation, treat in time, and follow up properly. These are the cornerstones of success for success against tuberculosis. Again, I emphasize, insist on microbiological diagnosis, avail of WHO accredited rapid diagnostic, WRDs, in the form of line probe assay and gene export, both in pulmonary and extrapulmonary TB equally. Strictly discourage empirical anti-tuberculosis therapy, particularly where DRTB is suspected. Never undermine the importance of meticulous counseling, because properly counseled is half of the battle won. Keep in mind, paradoxical responses do exist in tuberculosis. This is similar to something that we see in HIV. For example, there is clinical worsening, there is radiological worsening, but the reason may not be DRTB. The reason could be just reconstitution of the patient's immunity. Hence, always whenever you have clinical and radiological worsening, confirm microbiologically whether there is a presence of DRTB, and never empirically start the patient on DRTB therapy where there is a clinical or radiological worsening. Achieving optimal cure rates are possible in DRTB too by adhering to DST guided, patient-centered and a rational approach. Hence, let us join our hands against this battle of TB, and we are indeed on the move to kick out TB. Thank you so much.
Thank you, Dr. Ketki. A very nice information up to the mark. Now there is one question: how to diagnose and treat microbial bacteria, mycobacteria other than tuberculosis?
Yes. So mycobacteria other than tuberculosis, also called as non-tuberculous mycobacteria, can also be confirmed microbiologically. So the same battery of tests which are available to diagnose pulmonary tuberculosis can also be used to exclude pulmonary TB and confirm NTM. In the form of any sample, a sputum sample can be subjected to first acid-5 bacilli smear. If smear is positive, we have differentials in the form of pulmonary TB or NTM. Then we can subject the sample to culture, and subsequently on culture, there is a term which is called as Mycobacterium tuberculosis complex grown, or on culture you can have non-tuberculous mycobacterial complex. And there is something just like we have line probe assay for confirmation of Mycobacterium tuberculosis and drugs. There is a specimen, there is a kind of test which is available for NTM in the form of species identification test, which can be done on the culture sample, and we can confirm which particular species of NTM the patient is harboring.
Thank you, madam.
Thank you so much.
Now we'll move to the next speaker, a well-known nephrologist, Dr. Rishi Deshpande. I request Dr. Dakshini Kashyapi, and I am a CGP member, to introduce the speaker. Over to Dr. Dakshini Kashyap.
Hi, friends. So Dr. Rishi Deshpande is a consultant in nephrology and a renal transplant specialist at Jaslok Hospital and Research Center, Mumbai. After his MBBS and MD, Dr. Deshpande completed DNB in nephrology in 2002 and DM in nephrology in 2003. He received a gold medal in DNB in nephrology, awarded by Dr. APJ Abdul Kalam, the President of India at that point in time. Dr. Deshpande trained as fellow in nephrology at the University of Toronto, Ontario, Canada for 2 years, and in kidney transplantation for 1 year in a program accredited by the American Society of Transplantation, Toronto, Canada. Dr. Deshpande's areas of special interest are hemodialysis, peritoneal dialysis, kidney transplantation, and resistant hypertension, which is difficult to treat. Dr. Deshpande has presented multiple papers at national and international conferences and has several publications in peer-reviewed journals to his credit. Today, he will speak on kidney transplantation, an optimal approach for ESRD.
Thank you, Dr. Kashyap, for the introduction. Very kind of you. Thank you, IMA, for inviting me to address this august audience. It's always a pleasure. I'll share my screen with your permission. Yeah. Visible?
Yes, sir.
Thank you. So today's topic is very simple. First of all, I would like to congratulate Dr. Kirti. I mean, that was really a very informative talk on tuberculosis. I just heard that entirely. So today's topic for the day that was given to me was kidney transplantation, an optimal approach for ESRD. So more like a basic talk for kidney transplantation. I'm sure that we must have discussed this in the past, and for some of you, it could actually be a revision. So for those of you, I'm a director of nephrology academics at GSLOC, and I run the critical care nephrology program as a director at Sir H.N. Reliance Foundation Hospital. So this is how I would like to address my talk. I would like to share with you the general burden of end-stage kidney disease, the options available to the patient with this disease, how is the scenario across our country, what have I learned how to manage the patients in the COVID-19 pandemic, then understanding kidney transplant from the patient's perspective, and just summarize my talk at the end. So this is the prevalence of end-stage renal disease and CKD. So if you look at CKD, it's 800 per 10 lakhs, whereas the prevalence of dialysis patients is 150 to 200 per million. So, almost 1/4 of the patients with CKD never reach dialysis. And that's not exactly a happy scenario, because it actually means that they die before they come to a point where they need dialysis. And they are not dying from renal failure, they are dying from other systemic illnesses, primarily cardiac and neural stroke. So basically MACE events. So management of CKD is very important, and that is, at the level of the family physicians. Not a topic for today, but some other time we will discuss this more. So this is what happens to the patient with end-stage renal disease. In addition to the kidney that is reflected in your blood test, you patients have anemia, bone disease, brain problems, pulmonary edemas, volume overload, high potassium, infections, neuropathy, conversions, strokes. So lots of medical problems that we have to manage in patients with renal injury. So once somebody is diagnosed with end-stage renal disease, what does that mean? End-stage renal disease means irreversible loss of kidney function. The duration should be more than 3 months of history, and the patient, there should be reversibility in any form should be ruled out by the treating doctor. That means that the patient has no choice now but to accept one of the RRT. What is that? Renal replacement therapy. And there are only few options. One is kidney transplant, which we are discussing today. The second is dialysis. So it could be hemodialysis or peritoneal dialysis. So this is for patients who have end-stage renal disease, who are either unwilling for transplantation or who don't have a donor. And that is a more frequent problem. Unwilling is small. Not having a donor is much more common. And conservative treatment. So this is for family physicians again. Every patient with end-stage renal disease, should not actually go for kidney transplant or dialysis. There is a section of population who have reached a certain age, who, if they make a conscious choice that they do not wish to extend their longevity at a cost of quality to life, or they don't want to subject themselves to all these procedures, I think even that should be respected. But I mean, that is a topic for some other day. But that should be, as doctors, we need to respect the patient wishes also, and not actually force them into dialysis or whatever. So like I said, dialysis is basically 2 types, hemodialysis and peritoneal. In India, 95 or even 99% of patients would be on hemodialysis. Peritoneal is a very small chunk of our patients. Peritoneal is not as effective as hemodialysis the way we do it, because the way we do it is, if we say dialysis 3 times a week, the next thing we hear is, can I do twice? Who has not heard this in practice? All of you out there who have your GP clinics, you know this. Patients love to have less dialysis, even though they have been told several times that less will make you much sicker in the future. They are not going to listen. So that is the scenario we practice in, where here if we try to put them on peritoneal dialysis, which is much more expensive, which is, they have to do themselves, the efficiency really is not as good. And anyways, after 2-3 years of starting PD, most of them will end up on hemodialysis, either because of infections or because of efficiency problem of PD. So dialysis, the typical way we advise that is 4 hours 3 times a week, which is good. However, a much superior form of treatment is kidney transplantation. So basically, we all know what is transplant. You have a healthy donor who is willing to give a kidney. You take that kidney and engraft it into the recipient. So it could be either a deceased donor or a living donor. I right now serve as the chairman of the kidney transplant committee of ZTCC Mumbai. So we run the cadaver donation program in Mumbai, and this is a voluntary work that I do. And I am happy to share that the rate of deceased donor transplantation in our city has definitely gone up. But even though through the COVID time, we were able to carry on with the cadaver transplant program. And, even though the waiting list is not coming down, it is not because the donors are not increasing, but it is simply because the number of patients waiting for transplant is going up. Okay. So, supply, the demand is often exceeding the supply. The living donor transplantation is the most common form of transplant that we do in our country. So 90% of my transplants will be living donor transplants. So last year I did around 53-55 transplants, of which not more than 5 were deceased donor. Most of them were living transplants. So living donor in India, the rule is Human Organ Transplant Act. It has to be a related donor. No commercial transaction can be allowed, and the permission has to be obtained from the appropriate authority, either the hospital or the government, depending on the relation. So, for example, if it's a mother or father, the hospital can give you a permission to transplant. But suppose it's a maternal uncle or a paternal uncle or brother's wife, it has to go to a government to rule out anything that has no commerce has been involved in the transplant and the relation is established. So for that, it has to go to the government. Now, the next question you would ask me is, when would you transplant? Would you wait for somebody to go on dialysis to transplant? Not the smartest thing to do. The best time to do a transplant is before the need for dialysis arises. So once you have diagnosed that there is nothing reversible about the kidney problem and you see that the kidney problem is progressive, once the GFR has dropped below 30, going towards 15, or from 15 to 10, please go ahead and transplant the patient. Do not wait for the patient to become sick and needing dialysis. This is called as preemptive transplant, and all results have shown that it is the best form of renal replacement therapy in CKD. So if you look at deceased donor survival versus living donor survival, this is what is seen, that the living donor survival is much more than deceased donor survival. And that is not surprising, because in living donor, everything is controlled. The donor is much better assessed. The cold ischemia time is so much less, because you are doing it in a controlled setting, 2 operation theaters next door. You take the kidney from there and you put it here. Whereas in deceased donor, it comes from some other hospital, it's stored in cold, timings are not according to your control, so lots of things. However, deceased donor transplant is still much more superior to dialysis. So then you can think how much superior living donor transplant will be to dialysis. So other options to consider if you have a living donor who is not matching well is either to go for a paired exchange kidney, or better off to go for a across the blood group transplantation. We have been doing across the group transplantation for the last 14 years now, and I can share with you that our results with across the blood group transplant are as good or very, very similar to where the blood group is matched. So it really doesn't matter. So paired exchange transplant primarily we use when there is a HLA mismatching, as in somebody has a cross match positivity. Then in that situation, it is better to go for a paired exchange than to go for transplant with the same donor. So So who is eligible to go for a transplant? So every patient with chronic kidney disease stage 5 should consider kidney transplantation. The one thing, a rule of thumb I would tell you is you need to be sure that this patient should survive at least 5 years after the transplantation to put him through the transplant. If the patient has any disease, neurologic, cardiac, malignancy, anything that you feel will not allow him to live for more than 5 years, please do not transplant him. It's a human donor who is giving a kidney. We need to respect that. It is much better that this patient goes on dialysis. However, a patient who is not having these issues should be going for transplantation, and when, sooner the better. Once the GFR is close to 15, please go ahead and transplant that. Okay. So how do you decide? So this is what I was talking about. So there are some absolute contraindications, like patients who have, say, advanced heart failure, advanced liver failure, lung damage to the point where they are supplemented with oxygen at rest, active malignancy. These are absolute contraindications. You do not transplant these patients. Okay. Only otherwise, if these things are absent, you should go ahead with the transplant. So what are the steps involved? You identify the patient. You explore the possibility with the patient that finds, see, now you have a disease which is getting advanced. You are reaching the point where you will either need to go for dialysis or transplant. Transplantation is superior to dialysis because you will live longer, your quality of life will be better, and your overall expenses will be less as compared to dialysis when you look over a 3-year period. Then once this is done, then you should be deciding which transplant center you want to do the transplant at. Choose your doctor and refer the patient early. Do not wait for the patient to become very sick. So this is what has to be done at the level of the family physician. Once you know that the patient has this kidney disease and is going for a RRT, if there is a possibility of transplantation, you choose the center, choose a doctor, and send him to the doctor. Right? Then the doctor can do all the tests required and decide, is the patient right for transplant? If the patient is fit for transplant, if there is a living donor, go ahead and do it preemptively. There is no living donor, register them for cadaver transplant and put them on dialysis when the time comes. So what are the things we look for when we look at matching? One is blood group matching. Like I said, matching is when available, good. If not available, doesn't matter. Incompatible works just as well. Tissue matching is important. So when you do a cross matching, so it is not so much as HLA matching that matters, it is the mismatching that matters. And what matters much more is, are there antibodies in the recipient, in your patient, against the donor? Because if they have anti-human antibodies against that donor, then that graft, the kidney, will not live long. So then it is not a good idea to transplant. You should look for another donor, or you should consider desensitization. So those are advanced things that we do routinely now. But I mean, that is for patients who do not have a donor with a matching. So then we do the cross matching, what I was just discussing. Then additional sizes factors would be like donor age, kidney size. But honestly, we can't really choose much because of the paucity of donors. That being said, if we feel that something is coming out as an absolute problem, then we would not transplant that patient. So once they have a transplant, you need to understand that to ensure that the graft lives for a very long period of time, we have to be sure that the patient has a long-term graft survival and patient survival. They have to take their medicines regularly on time, and these medicines have a narrow therapeutic margin. So missing a single drug also can put the patient into a problem. So it is important that the medicines are taken absolutely regularly. So this is how the window goes, how we decide on the transplantation. So when the patient is admitted for transplant, it's something like chemotherapy, so where they have an induction phase and a maintenance phase. So during the induction phase, we would use monoclonal antibodies or another medicine, special like anti-CD20 antibodies or something, depending on what we have assessed in the patient, to decrease the risk of rejection. And then at the time of transplantation, the patient is started on immunosuppression. Standard is triple immunosuppression, where we use a calcineurin, mycophenolate, and steroid. We do steroid free when we feel that the risk of the rejection is very less. Otherwise, we keep them on low dose steroids. There are several induction agents available for us to choose between. So once we have decided these are the various induction agents we use, So we use thymoglobulin a lot. It's a polyclonal antibody which is good in patients who are sensitized or at a higher risk of rejection. Patients who are at a very low risk of rejection, basilizumab or interleukin-2 receptor antibody is another one which we use very commonly. So the advantage of using them is the risk of rejection goes down. Choice of agents, to depend on things like how high is the risk of rejection, and that depends on what workup we have done for your patient. What is his level of sensitization? Does he have antibodies? Even though not against the particular donor, but maybe against other humans, that is also a risk factor. And they would need something like thymoglobulin to go ahead with, and whether they have any viral infection. So somebody who has been treated for hepatitis C, I might want to choose cyclosporin over tacrolimus. And sometimes centers can have their own preferences also. So maintenance therapy is usually triple drug therapy, and these are the different classes of therapies available now in our city. So we have steroids, we have calcineurin, both tacrolimus and cyclosporin. We have antimetabolites, either mycophenolate or azathioprine. And the other drug which is gaining ground is an mTOR inhibitor, sirolimus, or even better, everolimus now. Belatacept is coming up of age, but since it's an injectable therapy, it has not found a lot of takers for now. Particularly as a CNI free protocol, it is gaining ground. So by using these drugs better, we are able to prevent rejections and decrease the incidence of post-op complications even further. Suppose this is what I always tell the patient before the transplantation. If you are doing a transplantation, there are three things you need to know. One, that the risk of rejection will be very high if you miss even a single medicine. Second, you are at a risk of getting higher sugars post-transplant because the medicines are used. You may need medicines to control the sugar. The risk of infection will be higher because it will be immunosuppressed. So during the COVID, it's not such a big problem because all of us are using masks. But particularly you will remain to use a mask for the rest of your life, and you have to be careful of not eating in smaller places, not carrying food infections and things like that. In our community, most of the reasons for not taking medicines religiously, either it is in form of financial reasons, because that is a very significant problem, or there is not enough social support for these patients. Mental health issues are lesser in our practice, but they are present, and we need to know that everything has to be taken as a wholesome package. The family has to be fully counseled, that they will have to make sure that they remain adherent to their medicines. Otherwise, there's no point in doing the transplantation. So, is it necessarily better kidney transplant compared to dialysis? Look at the parameters. So this is survival, and when you look at survival curves, you know that the blue one is a dialysis, the green one is a transplantation. So transplantation, the survival benefit starts right after the transplantation and continues over years together. Okay. On dialysis, actually, as years pass, the problems become worse with time. Okay. So lower cardiac events are there on cardiac transplant as compared to dialysis. So on the left side is favoring transplantation, on the right side is favoring dialysis, and all these events, if you see, they are lesser in transplant. All cardiac events, heart attack, myocardial infarctions, IHT, heart failure, any cardiac event, they are all lesser. There's an improved quality of life in after transplantation, whether it is physical, mental, general health, whichever way you look at it. So the relative benefits of transplant would be, there's a lesser mortality, there's a lower risk of cardiovascular events, and improved quality of life. So what is the scenario in our country? This is the scenario, from different data centers that we have seen. And most of the times, if you see, the living donor is far more, 80 to 90% as compared to deceased donor. As if you look at kidney graft and patient survival, this is cumulative, where the patient survival even is very good, even at 5 years post transplantation, whereas the graft survival after 3 years, after 50, see, this is 15 years. And after 15 years, you see the graft survival starts going down much more. This is 80% at 15 years, right? Whereas the patient survival is good till almost up to 20 years post transplantation. And this is a programs in India with data showing it. So the transplantation challenges are that everything is individual. So Patient has to, the awareness for deceased donor is not so much even now. Some communities, they are not in favor of donations, and high cost of immunosuppression also puts off some people who would like to continue on some form of charity dialysis when they don't have the support. So there are lots of things that can be improved to improve the kidney transplantation scenario in India even further. The simplest thing, like the rules at the ground level need to change. I mean, and sometimes it's shocking to find that a parent donating a kidney to the child needs to go get a police verification certificate because it is something that our government insists on. So it is very surprising. So what are the major COVID-19? What have we seen? So we had a huge burden of COVID-19, and who would know that better than all of you out there, who really were the first line of defense against this disease. So during the active COVID-19 phase for 6 months, we were not transplanting. We started gingerly, taking a lot of precautions. Now I can share with you, last year through the COVID, like I shared with you, I did some 53 or 55 transplants, and all of them have done well, and nobody has got COVID post-operative. So we are actually, the hospitals have now evolved, and the programs, the policies in place are actually able to prevent transmission of COVID in the hospital. So during dialysis had a rough time during COVID, and initially they were closing down hospitals, and that was really scary for our patients on dialysis. So, and then there was this advisory to stop elective surgeries because of the shortage of manpower and resources. So then slowly, as things got better, transplant programs we started in most of the major centers, and we were I was a part of this multi-center study that we published in which showed that 100% recipient survival, graft survival, donor survival during the COVID pandemic, that when it was done in our country. And even this data was refreshing, that who got transplanted and developed COVID, most of them came out absolutely well. From the patient's perspective, this is what is important for at the level of family physician, because they'll come to you saying, what should I do? So what should you do is, first of all, look at the age of the patient, look at his quality of life, and decide whether he should go for aggressive treatment, continue treatment or not. If yes, then first decide if the patient has CKD stage 5, is he a candidate for transplantation? If yes, refer to a transplant center and a nephrologist, and then let them take it from there. And if no, then consider starting putting in AV fistula and preparing for dialysis. Once the patient goes to the transplant center, then the nephrologist has to decide whether he can wait for the donor evaluation, or does he need to start dialysis till then. And if there is donor is available, a living donor within the family, within the rules allowed by our government, we do the transplant. Timing wise, preemptive is the best as compared to waiting for starting dialysis. And the advantages of transplant, like I've shared with you, which I'm repeating, is increased duration of life, better quality of life, and lower expenses as compared to dialysis over a 3-year period and later. So patients' interest in kidney transplant is a fundamental process that patients need to understand that transplantation is better than dialysis for them. They need to understand also that they need to take the medicines lifelong after they get a kidney. So their patients are able to go back to jobs. So who are the patients who go for a transplant? Younger patients, patients with more education, patients who have a stable source of income, patients who have a good medical insurance, patients who are likely to remain employed post-transplantation are ones who go for transplant maximum. Okay. So when you look at when this was a data that they looked at from different doctors, and it was shocking that only 18% of the patients who were in CKD were even discussed kidney transplant as an alternative before they reached to the point of dialysis. So quality of life benefits should be known to the patient, and what would be helpful is if the patient is with a nephrologist when the GFR goes down to 30 at least, because then they are the best suited doctors to decide which way the patient will be benefited in conservative treatment, dialysis, or kidney transplant. So These are the guidelines from the KDIGO, which is Kidney Dialysis Initiative. It was a world over guideline that have been published, and they recommend that timely referral for planning renal replacement therapy in patients with progressive kidney disease, chronic kidney disease. It improves the outcomes. So do not wait for patients to develop absolute indications before referring for dialysis. And it is much better when CKD care is planned and not sudden. If I was to summarize, we'll say that the incidence of end-stage renal disease is increasing annually. All of us know that our burden of patients is increasing as time goes. Comparison, so the options that they are available, kidney transplant remains the treatment of choice because of the benefits that I have mentioned to you. Despite the COVID, transplant should be done. That is my belief also, and I'm practicing it actively. And it remains superior to dialysis even during the COVID era. Thank you so much for your kind attention. If there are any questions or discussions, we can take them with the chairpersons.
Yeah, thank you very much, Dr. Rishi Deshpande. I can just see there's one question. Can a 65-year-old man with well-controlled diabetes and hypertension, but having a normal renal function, donate the kidney?
Well, 65-year-old doesn't matter. In 2008, I did a kidney transplant. I had just come back in 2006. In 2008, I accepted a donation from a donor of 78 years of age. And at that time, the Human Organ Transplant Act was not allowing any donor above 75. So we actually had to go through pillar and post to get a permission. And then it has firmly established now that the age less than 18 is a contraindication. At the higher end, there is no contraindication. So any age can donate, provided they have normal kidneys. Now, it is important to understand that biological and chronological age of the kidney is not the same. You can have an age of 65, but the kidney could be absolutely healthy and normal, or you could have an age of 50 and have weaker kidneys. So I have accepted donors right up to 82 years of age when their kidneys were healthy. And I can share with you that the outcomes in these patients are very good. However, in your patient, the problem is not the age. The problem is the presence of diabetes. Now, diabetes comes out as an absolute contraindication to kidney transplantation. Diabetic donors are not accepted world over. That is simply because of the reason that, in our medical practice, when we take the oath, the first thing we say is do no harm. And how can we allow a person to put himself at danger of developing, as it is impossible to predict which diabetic patient is going to become a kidney patient in life. Right now, this is the scientific part. The practical part is, if your diabetic patient has a son who needs a transplant and he has normal kidney function and he has no proteinuria, no macroalbuminuria, his diabetes is absolutely under control. He is, otherwise understanding the risks and wants to accept the risks, then that is between you, him, and your nephrologist.
Okay. There are no more questions. Thank you very much, Dr. Rishi Deshpande, for an excellent presentation. It is we always love to hear you on this IMA platform. Thanks a lot.
Thank you.
Yeah. Friends, now we move on to the last lecture of today's session, and that is on tuberculosis. And we have Dr. Rajendra Nanavre who will be speaking. And just introduce sir in short. Dr. Rajendra Nanavre has worked at different levels, including medical superintendent in Group of TB Hospital, Shivri, for the last 33 years. He has worked as editorial manager for the Indian Journal of Tuberculosis. He has worked as consultant for International Union Against Tuberculosis and Lung Diseases. He was a member of Pharmacovigilance of Drug Safety Monitoring Committee, that is at ICMR, for a pilot project in new anti-TB drug Bidaquin for MDR as well as XDR TB patients. He has worked as a lecturer and was an examiner for postgraduate fellowship and diploma in chest and TB diseases for College of Physicians and Surgeons, Parel, Mumbai. He has presented more than 10 papers on TB in international and national conferences. He has also presented his work on transmission of TB in healthcare workers, a 5-year longitudinal study in World TB, and Lung Conference in 2015 in Cape Town, South Africa. He has also presented a paper on prevalence of MDR-TB in senior citizens in 2018 in an international conference on senior citizens. Today, Dr. Nanavare will be talking to us on diagnostic approach for tuberculosis. Over to Dr. Rajendra Nanavare.
Can I hear, sir? Thank you.
Yes, 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 sir.
Yes. Thank you, sir. Thank you for calling me for this session. Thank to the President, Managing Committee member of IMA. I will be talking on diagnostic. I have to share the screen now.
Yes, sir. Yes.
Sorry, as we are running out of time, but
Yes.
I will try to complete it very fast.
Yes.
I will be only talking on the diagnostic part. Can I start, sir?
Yes, sir. Yes.
As you know, tuberculosis is the killer of all time. It's the captain of all men of death. For the last century, TB has killed more than 100 million people, and TB was a death sentence for many. It is one disease with many names, called consumption, phthisis, Pott's disease. All are terms used to refer TB throughout history. TB has been known to mankind since ancient times. 1 in 4 died of the disease in 1880, and late 1980 it was a 1 in 7. Until the early 20th century, it was the greatest killer of all. Among the communicable diseases, TB is the leading cause of death worldwide, and now COVID-19. So what are the discoveries? The causating agent. On 24th March 1882, Dr. Robert Koch, a German scientist, announced the discovery of Mycobacterium tuberculosis, the bacteria that causes TB. He was awarded Nobel Prize in Medicine in 1905. In 1982, a century after Dr. Koch's discovery, the first World TB Day was sponsored by WHO and Union. World TB Day is held on March 24 each year in commemoration of Koch's recovery. This is a picture of Dr. Robert Koch, who discovered Mycobacterium tuberculosis. In 1993, World Health Organization declared a global emergency for the tuberculosis. Why everybody is concerned? Because it kills young adults. Premature death of the infected a prominent feature. Too many are infected with the HIV. Open case, which we call sputum positive of tuberculosis. In fact, a few around us, few around his or her environment, and social burden to the family, society, and nation. So what happened? Why we failed to diagnose tuberculosis? Because of lack of infrastructure. Control is plagued with lack of accurate, robust, and rapid diagnostic methodological technology. Diagnostic services are poor, so we failed at individual and community level. Early death and burden to the societal, social infrastructure and economic loss. So what is the present scenario? It's caused by Mycobacterium tuberculosis, mostly affect lung, it's curable and preventable, spread from person to person through air. When the people with lung PTB cough, sneeze, or spit, they propel the bacteria into the air, and a person needs to inhale only a few of this bacteria to become infected. As you know, 1/4, means 1/4 of the world population has a TB infection, which means has been infected by TB bacteria, but not yet ill, means he is not getting with the disease and cannot transmit it, and it is called latent TB. Or some say it is more than 50% in Mumbai, but the scenario is we can't, we have not done such studies. So still we believe that 1/4 is okay. People infected with bacteria have a 5 to 10% lifetime risk of falling ill with TB. Now this infected person in their lifetime, they got a chance to become a or get a disease, and that is 5 to 10%, mostly in the first 2 years. Those are compromised immune system, people living with HIV, malnutrition or diabetes, or people who use tobacco, also alcohol, having a high risk of falling ill. When a person develops active TB, the symptoms such as cough, fevers, night sweat, and weight loss may be mild for many months. This can delay. This lead to a delay in seeking care. So this is the reason, because they are mild. People think it's a common disease, so they don't care for that, and result in transmission of bacteria to the other, and also cause the disease to be in an advanced stage. People with active TB can infect 5 to 15 other people through close contact over the course of a year. Most common is a household contact. Without proper treatment, 45% of HIV negative people with TB on average, and nearly all HIV positive with TB will die. So if the proper treatment not given, HIV people are going to die, and HIV negative people, mostly half of them are going to die. So what is the background? A total of 1.5 million people died from TB in 2020, out of which 214,000 were people with HIV. Worldwide, TB is the 13th leading cause of death and second leading infectious killer after COVID-19. In our country, it is a third leading cause of death. In 2020, an estimated 10 million people fell ill with tuberculosis worldwide, out of which 5.6 million men, 3.3 million women, and 1.1 million children. TB is present in all countries and in all age groups. It is curable and preventable. MDR TB remains a public health crisis and a health security threat. Only about 1 in 3 people with drug-resistant TB access treatment in 20. It's 1 out of 3. Means 2 people are missing. Globally, TB incidence is falling at about 2% per year. And between 15 and 20, the cumulative reduction was 11%. So 2% is very less. We require much more. I'm going to talk about the preventive part. This was over half a way to end TB strategy milestone of 20% reduction between 15 to 20. Ending the TB epidemic at 2030 is among the health target of United Nations Sustainable Development Goal, and our country has decided to end TB by 2025. So diagnosis of TB, every individual presenting with 2 weeks of cough or abnormal chest radiograph should be investigated for a TB. WHO endorsed sputum tests like smear, expert MTB ref, line probe assay, and liquid culture should be used to diagnose TB and MDR. And all cases must be notified. This is very important. All cases must be notified to the local public health authority. That notification is compulsory. Blood test, antibody test, and IGRA are not recommended for activity. This should be done because I have seen a lot of people are still doing blood tests to diagnose TB. For extrapulmonary TB, sample from the site of disease must be tested using gene expert, histopath, and culture. So this is an algorithm which tell us how we should go for a case of tuberculosis. So all presumptive TB cases or a key population, all TB patient or non-responder should do CBNAT first. If the CBNAT shows RIFA not resistant or resistant is not detected, then you can start with a drug sensitive TB. As Madam has explained, how the drug-resistant TB should be treated. And the second part is a first-line LPA, in which if we find H resistant, then we go for a H mono or poly layered TB regime. So the second part where the RIFA resistant is detected. Now in such condition, we should go for a first line LPA, second line LPA, liquid DST, that is the drug susceptibility test, and in that Z, that is the pyrazinamide, bedaquiline, clofazimine, moxie, linezolid, and delamide should be done as a DST, and after completing pre-treatment evaluation, which is a very important part for the newer drug, because if you do the pre-treatment evaluation, we can be knowing that the person is not having any problem starting the new drug. And if the LPA results are available and say yes for rifampicin resistant, no additional resistance are detected, H resistant detected with CAT-G or INHA mutation, and FQ resistant not detected. Then we can start with a shorter oral regime. I'm not going to go for this treatment part. Only I am going to tell you how to diagnose. And if S for H resistant detected and FQ resistant is detected, then we are going for. Now we know that in a drug resistant patient, H mono or poly, then shorter oral regime and longer oral regime are only the regimes, and the modified if needed as per replacement table is there in the new guideline. So diagnosis of extrapulmonary tuberculosis. Previous lecture by the madam has told us that it's very difficult to diagnose extrapulmonary. So the importance of seeking microbiological and histopathological diagnosis of EPTP, and then emphasis the need of collecting appropriate sample. The sample should be appropriate. Also, that all patients, including children who are suspected of having EPTP, should be appropriate specimen obtained from the suspected site of involvement for microbiological and histological exam. In clinical practice, this will mean collection of sample from bodily fluid like cerebrospinal, pleural, ascitic fluid, lymph node, and other tissue, and aspirate like a gastric aspirate, mostly done in children. So no single test has a high accuracy. It is important in EPTP. It is important to perform microbiological like a NAT or culture as well as histopathological investigation. So several studies have and WHO endorsed the use of gene expert, that is MTB-RIF, for meningitis, lymphadenopathy, and pediatric TB. In 2016, gene expert MTB-RIF should be considered a central test in the work of EPTP and should be used along with existing tools like microscopy and liquid culture, which are the most sensitive technology for detecting of Mycobacterium tuberculosis, and histopathological, that is a biopsy to arrive at the final result. It is important to note, gene expert does not have a high sensitivity for pleural sample. So pleural biopsy and culture are the important tool for TB pleuritis. In addition to gene expert, there is a role for non-specific biomarker such as adenosine deamide, that is ADA, and unstimulated free interferon gamma in sterile foods such as pleural, peritoneal, and ascitic. This biomarker can be used in combination with microbiological and histopathological investigation. Now, the diagnosis of tuberculosis can be clinical, bacteriological, and relevant. So, first we'll talk about the clinical diagnosis. TB primarily affects lung, other organ system also affected. Lymph node and pleural TB are the commonest form of extrapulmonary TB. Extrapulmonary TB is more common in patient living with HIV, and clinical manifestation can be systemic or organ specific. So, TB can involve, extrapulmonary TB can involve musculoskeletal system like bone and joint of upper and lower limb, pericardium, kidney and genitourinary system, skin, eyes, breast, larynx. Clinical presentation will depend on organ system involved. Ideally, all TB patients should go DST, undergo DST because person with because of drug resistance and it cannot be diagnosed clinically, so you should go for the DST. Person with previous history of TB or not responding to standard therapy must undergo DST for first-line anti-TB drug or DST like gene expert, LP and liquid culture are recommended. Lastly, the tests that are intended for detecting LBTMs, latent TB are TST and IGRA must only be used for latent TB infection diagnosis in selected high risk group and should not be used for detection of active disease. Now the clinical part. Tuberculosis primarily affects lung, that is 85%. It also affects other organ, which is called extrapulmonary TB. Extrapulmonary environment can occur in isolation or along with pulmonary focus. Clinical manifestation can be general or organ specific. In endemic setting, a high index of suspicion should be exercised. So, in general, these things are unexplained fever of long duration, loss of weight, loss of appetite, night sweat, fatigue or tiredness. The children failure to thrive may be the only symptom. In pulmonary TB, it can be chronic cough, productive or more than 2 weeks, hemoptysis, chest pain, dyspnea, systemic symptom of fever, weight loss, and anorexia. The other most common EPTB is a lymph node. The commonest form of EPTB affect children and young adults, most common in human. Superficial or deep lymph node may be affected. Superficial node usually cervical, single, multiple, unilateral or bi. Deep node are intrathoracic, abdominal, retroperitoneal, and may be associated with systemic symptom. Common presentation is pendulous, single or multiple, usually bilateral or enlarged peripheral lymph. Next is a pleural TB. Pleural effusion. Second commonest trauma extrapulmonary may be present with cough, chest pain, or shortness of breath, with or without fever and weight loss. In emphysema, there may be sign of toxemia, digital clubbing, and intercostal drainage. In emphysema, we require intercostal drainage. So, in pleural effusion, it is simply pleural tapping is done, but emphysema is a little chronic condition. Tuberculosis of central nervous system can be meningitis or tuberculoma. Most severe manifestation of extrapulmonary TB, 70–80% of cases of neurological TB. Prognosis depends upon early diagnosis. Clinical features include fever, headache, seizure, or neck stiffness. Developing country, meningitis is a disease of childhood. Patient living in the HIV account for more than 50% of TB meningitis in industrialized nation. Silent pathological features include inflammatory, meningeal exudate, vasculitis, encephalitis, disturbance of CSF circulation and absorption. The stages of this clinical stages, stage 1 is a non-specific constitutional symptom, which fever, headache, irritable and malaise, few or no clinical sign. Second stage is drowsy and lethargy. Clinical sign of meningeal irritation, cranial nerve palsy, vomiting and seizure. And stage 3 is a stupor or coma, often accompanied by paresis, hemiplegia or paraplegia, hypertension, decerebrated posturing, death and long-term sequelae in 50 and 40% of patients. Tuberculoma, less common than meningitis, clinical feature anatomical location, seizure, commonest presentation, present with headache, fever or local neurological deficit, differential diagnosis of neurocysticercosis and neoplasm. A TB of abdomen may be manifested enteritis or peritonitis. Enteritis is more common in adults and is due to swallowing of infected sputum. Peritoneal TB result from reactivation of a latent peritoneal focus or as a part of biliary spread. Peritoneal TB may occur as a wet type with ascites, dry type with adhesion, and fibrotic type with fomental thickening and loculated ascites. Most common site is the ileocecal region. Abdominal pain can be colicky or due to luminal compromise or dull due to continuous involvement of mesenteric lymph node. Abdominal distension, doggy abdomen due to mesenteric adhesion. Ileocecal and small bowel TB, palpable mass in the right quadrant or a complication of obstruction, perforation or a malabsorption in the presence of stricture. Constitutional symptoms are fever, weight loss, and fatigue. Biliary, common in immunocompromised, multi-organ ailment, organomegaly, visceral side with rich vascular supply like liver, spleen, and bone marrow, brain may be affected. Clinical symptom, subacute and non-specific. Chest symptom, obscure till late in the disease, cough and dyspnea often present. X-ray chest show bilateral biliary pattern, multiple less than 2 mm nodal, choroidal tubercle, neurological involvement may be present. Now the second part of the clinical is a bacteriological. So in bacteriological, how should be a test? So provide early and accurate diagnosis, simple, reliable, cost-effective, capable of discriminating between infection and disease. Because active disease, you have to treat. Infection patient is not, mostly in an infection patient is not symptomatic. Live and dead bacilla, because while we are giving a treatment, the test should specify whether the live bacilla in the follow-up or a dead bacilla, whether it is a mycobacterium tuberculosis or non-mycobacterium tuberculosis, whether it is sensitive or drug resistant. So diagnosis of active tuberculosis, active TB is a microbiological diagnosis, and every attempt should be made to get a bacteriological confirmation using a correct clinical specimen. According to international standard for TB care, all persons with cough lasting 2 weeks or more with abnormal chest radiograph should be evaluated for TB. All persons with previous history of TB or with treatment failure must go under DST testing. There are 3 methods that are recommended for microbiological diagnosis of active TB. These are smear microscopy, NAT, that is a nucleic acid amplification test. Most common is a gene expert, and LPA, and liquid culture, which is MISET 960. So the role of immunological tests. Following tests are not recommended for active TB diagnosis. That is serological antibody-based tests such as enzyme link immunosorbent assay or rapid immunoglobulin IgG or immunoglobulin IgM test, and interferon gamma release is IgR, that is a quantiferon TB or gold and TB. Serological tests are discouraged by the WHO and they are banned by the government of India. And with the tuberculin skin test and IGRA are meant for latent TB and are not recommended for active TB. So conventional method of diagnosis is for TB just smear, solid culture. Now it has been less done, and liquid culture. So smear microscopy, the century-old technique. The basic diagnostic tool requires minimal infrastructure, simple, inexpensive, quick result within 1 hour, suitable for sputum, pus, CSA, gastric aspirate biopsy, and also available at all levels like designated microscopy center to reference lab. These are the appearance when we see under the microscope. First is a Zillinen cell and second is a fluorescent. Nowadays, fluorescent has been replaced by LED microscopy. So Grading. It gives an estimate of the bacterial load, degree of infection at diagnosis, give an estimate of patient response to the treatment. So if the patient grade depends upon the number of bacilli, and it also tells the status of cure. So the negative is a 0 AFB 1 length, and scanty is 1 to 19 AFB, 1 plus, 2 plus, and 3 plus. 3 plus is a having a more bacterial load. Limitation of microscopy is the low sensitivity. It's less than 55%, and it is lower in HIV cases. Limit of detection, minimum 5,000 organisms per ml of sputum, unsuitable for possibacillus specimen. Mostly they are extrapulmonary. Cannot distinguish between Mycobacterium tuberculosis and non-tuberculous Mycobacteria, dead and alive bacilli, drug sensitive and drug resistant, required screening to avoid false positive and false negative, partially unsafe until stain. Yeah, that is, it is hazard to the healthcare worker. Fluorescent microscopy required dark room. Nowadays we are starting LED microscopy. So binocular diagnosis of tuberculosis is a recent development, more sensitive, quicker turnaround time, significantly enhance the early detection of disease and drug resistance. Molecular tool currently in use are GeneXpert, MTBRIF, and LPA first line and second. Molecular tests are rapid and sensitive tool for diagnosis of tuberculosis. Needed to be increased incidence of tuberculosis epidemic and length of time required by the classical diagnosis. As you know, classical diagnostic take like midget, a solid culture. They take a long time, especially among the HIV infected person. Allowed the application of basic molecular biology technique to the examination of clinical sample such as sputum and bronchoalveolar lavage for the molecular diagnosis of TB. Time required for the identification of mycobacteria has been considerably shortened, 24 to 48 hours in comparison to the time required by the microbiological test. GeneXpert new test that is revolutionizing tuberculosis control by controlling to the rapid diagnosis of TB disease and drug resistant. Drug resistant, like most common drug, Rifa resistant is seen. Test simultaneously detect MTB and resistant to Rifa in less than 2 hours. Comparison to standard culture, it takes 2 to 6 weeks to grow, and conventional drug resistant add 3 more. Information provided by the GeneXpert aids in selecting treatment regimen and reaching infection control decision quickly. Solid agar egg-based LJ media provide definite diagnosis, gold standard, suitable for all samples, required decontamination to eliminate common contaminant, required 1,000 organisms per ml of sputum, isolate available for DST or strain typing. This is a picture which shows how the colonies of the LJ media look like. And the limitation is slow growth of TB bacilli, delayed diagnosis 3 to 8 weeks, dependence on skill infrastructure not suitable for resource poor setting, require biosafety lab type 2 facility, and only reference lab or high-end private lab, cross-contamination leading to wrong diagnosis. This is a liquid culture, manual and automatic. The automated is a Becton and Dixon type. Component is a bar-coded tube with 7 ml medium growth supplements, fluorescent pinching, oxygen sensor, presence of oxygen in a medium, initially pinch, fluorescence, utilization of oxygen due to microbiome both allow fluorescence, confirmation by AFP staining, immunochromatography, protocol length 42 days, used for TB diagnostic and DST. Advantage: diagnostic and DST, high recovery in less time, higher sensitivity than solid culture, growth supplement to enhance growth. Disadvantage: require BSL bioseptic lab, grade 3, high risk for aerosol generation, expensive, require continuous power and air condition, high rate of contamination, growth need to be confirmed, AB. Now the laboratory turnaround, solid culture, that is a LJ media, 3 week for a smear positive sample, 4 to 8 week for a smear negative. Its egg-based medium, accepted level of contamination is 3 to 5. Automated liquid culture, commercial test system, 8 to 10 days for smear positive and 2 to 6 week for a smear negative. Phenotype DST, liquid medium commercial test system, 1 to 3 week for positive culture, and molecular testing, line probe assay for detecting drug resistant, that is a rifampicin, isogen, and fluorophenols. Second line injectable drug, 1 to 3 days. LP is performed directly on the AB smear positive specimen or indirectly on a culture isolate if the smear is negative. DNA target are amplified by PCR and hybridized to immobilize oligonucleotide target. Result can be read visually or using automated reader. CBNet, that is a gene expert. Detect MTB and resistant to RIFA using real-time PCR. Time taken is 2 hours. Fully automatic assay operational required, including uninterrupted power supply and temperature control setting. TrueNet uses quantitative real-time PCR for detection of microbial reflectors for perform rifampicin testing among MTB detected. 1 hour for TB detection and 1 hour for RIFA. Rapid identification immunochromatography assay to be performed on solid or liquid culture. 15-minute testing time. WHO recently announced post 2015 NTB strategy. A key component of this strategy is to push forward universal DST, which means that all patients should get a DST done at the time of their diagnosis to rule out the drug resistant status of that patient. At the very least, all patients with history of previous TB treatment failure or recurrence must undergo, because there is a high chance this type of patient having a more drug resistant. DST can be done by the 2 methods, genotypic and phenotypic. Genotypic method is based on molecular tests that detect mutations that confirm drug resistance. For example, mutation in the RPOB genes of MTB are strongly associated with rifampicin resistance. Example of genotypic test are Gene Expert, which is a hen genotypic MTBR plus commercially line probe assay. Hence, genotype is called line probe assay. Phenotypic method are based on detection on culture growth with or without TB drug added to the culture media. Phenotypic method includes solid and liquid culture. While solid culture take up to 2 months, liquid culture produce useful result within 2 weeks. For DST, both the WHO and ISTG recommend expert MTB test as the initial diagnostic, because it can be rapidly detect rifampicin resistance within 19 minutes with high accuracy. That's a sensitivity rate is very high, and allow clinician to initiate empiric MDR therapy pending confirmation with culture. LP or liquid culture and DST should be performed promptly if rifampicin resistance is detected using Gene Expert. Once culture and DST results are opted, MTB MDR TB therapy can be customized to the patient's drug susceptibility profile and must include a combination of at least 5 drugs, which the TB bacilli are sensitive. Madam has shown the chart which ABC group of the drug has shown. From there, we have to take first is a very important, and according to that, we have to take at least 5 drugs for this. Now, the radiological diagnosis. There is no radiological feature which are in themselves diagnostic of a primary mycobacterium tuberculosis infection, but a chest X-ray may produce some clue to the diagnosis. Below image shows consolidation of the upper zone with ipsilateral hilar enlargement due to lymphedema. These are typical feature of primary TB. The chest X-ray may be normal in primary TB. In fact, most patients infected are never unwell enough to require chest X-ray. So this is a X-ray which shows consolidation and hilar enlargement. Consolidation in the apex and hilar enlargement. So this goes in the favor of primary tuberculosis. Post-primary, secondary or reactivation is a more common in immunocompromised individuals, for example, those with HIV/AIDS, or those on immunosuppressive drug, or those with malnutrition and diabetes. Upper lobe are more commonly affected. Consolidation often extend to the hilum. The hilar structure may be distorted with the volume loss of the upper lobe. So this is a picture which you see in a post-primary. Miliary is due to the disseminated spread of mycobacterium which can occur either at the time of primary infection or on disease reactivation, and the prognosis is poor. Very fine nodules are typically seen scattered throughout the limb. So this is a X-ray showing miliary tuberculosis. Now this is a X-ray which shows a right apex or right upper and mid zone consolidation, most common into post TB, secondary TB. This is a cavity which is very common in tuberculosis. This is a hydronemathias. Now this is on the left side. The mediastinal structure has not shifted to the opposite side. But on the left side, on the right side, you see the HP means pneumothorax is on the right side, and the mediastinum is shifted on the left side. So it could be a tension pneumothorax, and that is an emergency. This is a hydropneumothorax, most common in TB patient. Second picture is also showing a hydropneumothorax. The fluid level is seen both on the right side. So now we'll start with the TB preventive treatment. Prevention of TB disease by treatment of TB infection is a critical component of National Strategic Plan 2025 by ending TB in India by 2025. So we are little earlier to the global. So we NSP proposed detect, treat, prevent, build approach scaling up treatment, preventive treatment. Tuberculosis preventive treatment would be the key to hasten the decline in TB incidence from present, that is a 2.5. Now the decline in TB is 2.5 annually, and to be required is 10%. So different study has shown that there has been almost 60% reduction in the risk of developing TB after tuberculosis treatment, tuberculosis preventive treatment. This reduction can go up to 90% among people living with HIV. So India has the highest estimated burden of tuberculosis infection globally, with nearly 35 to 40 crores Indian population having a TB infection, of which 5 to 10%, that means 18 to 36 lakh are estimated to develop tuberculosis disease annually. This may change after ongoing national TB prevalence survey data become available. From this large pool of infected but asymptomatic person, most patients of TB disease will arise. Several studies have shown that on an average, 5 to 10% of those infected will develop TB disease over the course of their life, usually within first 2 years of initial infection. The risk of TB disease after infection depend on several factors. Thus, most important being immunological status. This risk increase more than 25 among contact of a bacteriological confirmed TB patient. Contact of bacteriological confirmed patient compared to general population. The second is 16 to 21 times in case of HIV infection, or 3 to 4 times in other immunocompromised state like a diabetes. Reverse risk versus benefit assessment is critical with plan to expand active case finding and program management of TB preventive treatment to population beyond. Those currently recommended by WHO, for example, healthcare worker, migrant, people having diabetes, and other vulnerability mapped by state on active case finding. Study shows that 75% people who develop TB disease after contact with a patient of active TB are estimated to do so within 1 year. So 75% who develop disease of contact, they are going to develop within 1 year of TB diagnosis of the index patient, and 97% within 2 years. Molecular fingerprinting study further confirm the probability of developing disease is 1, 2, and 5 years. That is 45, 62, and 83% respectively. The eligibility of TB preventive treatment relies on ruling out active TB among individuals and group who are known to have a high risk of acquiring TB, using the test as an aid in decision making in people when available. So this is the algorithm, there's a cascade of TB finding and preventive treatment. Target population. First, you have to rule out whether he is having active disease. If it is active disease, then it should be go for a presumptive TB confirmation and start TB treatment. But no sign symptom, test for TB infection as per policy. Evaluate for tuberculosis preventive treatment, start TPT and systemic follow. A diagnostic test there are two types of tests. One is a TB skin test and other is TB blood test. Person, health providing have to choose which test to use. The factor in selecting the test include the reason for testing, test availability, and cost. Generally recommended to test a person with, generally not recommended to test a person with both, that is skin or blood test. A skin test required to visit with the healthcare provider. On the first visit, a test is placed. On the second visit, the healthcare provider read the test. That's called Malthus test. And tuberculin test is performed by injecting small amount of that called tuberculin into the skin of the on the lower part of the arm. A person given the tuberculin skin test must return to within 48 to 72 hours to have trained healthcare worker look for a reaction on the arm. Result depend on the size of raised arm, hard, induration and swelling, which is called hard area and swelling. Positive test, this means the person body was infected with TB bacteria. Additional tests are needed to determine the person has latent TB or TB disease. Negative skin test, this means the person body did not react to the test and that the latent TB infection or TB disease is not latent. Second test is a interferon gamma release assay or IGRA. The healthcare provider will draw the patient blood and send it to the laboratory for analysis. Positive TB blood test, this means that a person has infected with TB bacteria. Additional tests are needed to determine if the person has a latent TB or active disease. Negative TB blood test, this means that the person blood did not react to the test and the latent infection or disease does not like it. TB blood test is preferred for the people who have received BCG vaccine. People who have difficult time returning for the second appointment to look for a reaction of this. Now the message is, despite the progress made in tuberculosis control, WHO estimates that 10 million people develop TB and 1.3 million people die annually. Over 3.6 million cases were considered missing, either because they were not diagnosed or not notified to any national TB program. India account for one of the 3 million milling cases and account for 25% of global TB incident cases. A recent systemic review has shown that TB patient in India on an average faces a delay of nearly 2 months and visit to the 3 healthcare providers before a diagnosis. And the diagnostic delay are common in India context. Furthermore, a majority of Indian TB patients do not get tested for drug resistance. Early and accurate diagnosis followed by rapid treatment is critical to break the cycle of transmission. The purpose of this lecture is to provide a summary of best practices for diagnosis of active TB, drug resistant and latent TB. Diagnosing early and correctly is a critical part of the TB disease. Thank you.
Thank you very much, Dr. Nanare, for a very elaborative lecture on diagnosis of tuberculosis. I'll just take 2 questions. What is the optimal duration of treatment for MDR and XDR TB?
So it depends upon the person's because if it is HR, MDR, if it is HR and not resistant, there are some eligibility criteria. So if the person is eligible to the shorter regime, it takes 9 to 11 months. Okay. With the newer drug, Bedaquiline. Nowadays, injectable drug has been removed and only oral drugs have been started. So for the oral drug, 9 to 11 with 6 months of Bedaquiline for a 14 days intensive phase, at 4 tablets daily for 14 days and 2 tablets thrice a week for 6 months. So for a 9 to 11 months depends upon the sputum status. So the 9 to 11 months is a shorter regime, and for a longer regime, it is 18 to 20 months. So 18 to 20 months, minimum 5 drugs should be there, depend upon the sensitivity of the culture's DST report. Suppose the DST report shows H and R resistant, then it is given for 18 months. But if it is a pre-XDR or XDR, that means the resistant for H and R means isoniazid rifampicin with fluoroquinolone. Then it goes into the XDR or pre-XDR. In that condition, it should be 20 months, 18 to 20 months. When for XDR, it is 20 months.
Thank you very much, sir. Excellent presentation. We have already overshooted the time, so we'll.
Thank you, sir. Thank you. Everybody must be hungry for the lunch. Thank you, Kajal madam.
Yeah. I request Dr. Kajal Ahuja to propose a vote of thanks.
Good afternoon, all. I would like to thank our speakers of today's webinar, namely Dr. Ravindra Nikalji, Dr. Advaita Gore, Dr. Shruti N. Tapaiwala, Dr. Shubhangi Parkar, Dr. Ketki Utpat, Dr. Rushi Deshpande, and Dr. Rajendra Nanavare. I also thank our knowledge partners for the day, Sanofi Pharma, Apollo Hospitals, and Dr. Reddy Lab. I thank our chairperson, World TB Day, Dr. Suresh Doshi, and chairperson, International Women's Day, Dr. Sunita Shisagar. I thank Mr. Deepen Mehta, Mr. Piyush Kale, and Ms. Vaishali Tanpure from DigiShield, who have given us the platform for this webinar and handled all the technical details at the same time. I thank Dr. Anil Awad, President-elect, for conducting the webinar smoothly and efficiently. A big thank you to Dr. Sachin Patharkar for being MMC observer for today's session. Last but not the least, I thank you all the delegates for participating in this webinar in large numbers and making it a grand success. Thank you very much, everyone.
Thank you very much, Dr. Kajal. I again request all the people who are attending this webinar, register for the banquet of IMA Mumbai branch on the IMA's number. It is free, but the registration is compulsory. So do register on IMA mobile number. Thank you very much.
Thank you.
Bye.
Sure, thank you very much.
Yeah. Piyush?
Hi, Dr. Anil.
Yeah, close.
Piyush है sir. करो.